what value we are considering as cure. So there is a difference in recurrence rates even among these, from this study. The presence of 20, out of 127 patients who were considered biochemically cured after surgery, 24 had normal calcitonin, who had 25% risk of recurrence, whereas 103 had undetectable calcitonin concentration, and they just had 3% of recurrence. We also should consider that the calcitonin molecule is very heterogeneous. There are high molecular weight predominant molecules and low molecular weight molecules, and the secretion and disappearance rates of these molecules is different, and even macrocalcitonin can affect the assessment of these molecules. So from this study, which has looked at time to calcitonin normalization done by Mackens et al. From Germany, the calcitonin levels typically normalize within 1 week in node-negative disease. If there is significant node burden, or if the pre-operative calcitonin was more than 1,000, it's going to take much longer. So whether the disease was node-negative and how much was the pre-operative calcitonin also is going to determine. And apart from these, there are technical problems in calcitonin assessment. And again, Mackens et al. Have done a retrospective study in which they have looked at how prediction of biochemical cure in MTC is done by quantitative lymph node analysis. And they have found similar things that in patients who have undergone systematic lymph node dissection for MTC, pre-operative and post-operative basal and stimulated calcitonin were correlate with the stage of the disease. And absolute calcitonin levels primarily reflect the endogenous tumor burden, whereas with the rising calcitonin, there is disproportionate, with each node burden increase, there is exponential increase in calcitonin. I'll just skip these slides. So coming to the actual part, why I have put this premises, because we have very less number of studies actually comparing observation versus intervention in persistent, biochemical incomplete disease. The current concepts are clear in the management of loco-regional MTC, in which there is no debate, surgery, and asymptomatic metastatic MTC without structural disease. There is no systemic therapy required, and in metastatic MTC, it has to be individual-based. Then what are we actually debating? The controversial part is, it's not that simple. Management of the patients with incomplete biochemical response without a targetable disease, and with detectable disease without risk for local complications after initial surgery is where we are now debating upon. So what are the options for these patients? One is to just observe or active surveillance, as we call it, or whether we should surgically resect them, or can we use external beam radiation, or can we do any local directed therapies, systemic therapies. And despite routine lymphadenectomy or excision of palpable tumor routinely, the serum calcitonin concentrations often do not normalize in many patients. And critical evaluation of the need and timing of therapeutic interventions in these patients, and re-evaluation of the role of cautious observation in properly selected patients has to be done. So this is the ATA recommendation after adequate surgery. Here we are assuming that we have done adequate surgery. After adequate surgery, if there is detectable calcitonin less than 150, then we do ultrasound and then follow up after another 6 months with a repeat calcitonin. If there is a rising trend, we investigate further. If it is static and the patient is asymptomatic, we need not do anything. So choosing optimal imaging is also very important. In a study, it was seen that ultrasound neck is the more sensitive to detect local neck disease, and CT, spiral chest CT, liver MRI, and for bone, axial bone MRI and bone scintigraphy are very sensitive. FDG PET is not shown to be very sensitive. And amongst comparison of all the various PET CTs, F-DOPA was more sensitive. And long-term follow-up outcome in MTC with negative imaging on initial follow-up has been seen that there's a study done among 63 consecutive patients. In biochemically cured patients, that is, the criteria they've taken is less than 10 picogram per ml. The 3 and 5 year relapse-free survival were 94 and 90%. Whereas in incomplete cure patients, it was 78 and 61 at 3 and 5 years. So in patients with basal calcitonin levels less than 150, persistent or recurrent disease almost always confined in the neck. So even if we just follow these patients up without actually doing any intervention, because there is negative imaging and the calcitonin is high, it is not going to affect the outcomes. So implications from this study are that the natural history is not so bad, and even if it recurs, it's going to be in the neck, and they have good prognosis. So in the case of regional metastasis, there are no randomized trials. And in about 2/3 of the patients, even if we do resurgery, they are still going to have persistent disease biochemically. And so ATA recommends only surgical resection if, in case of selected patients of locoregional disease without distant disease, and compartmental dissection has to be done, not just berry picking. And the recommended treatment approach for persistent or recurrent disease should depend upon whether it is localized or not, the volume of disease, the precise location, and whether or not it is symptomatic, and what is the ret mutational status, as Amit sir has just said, and whether what is the likelihood of the structural progression. EBRT has not proven to be effective in many studies, and in fact it is going to increase the local complications. And if the detectable residual disease is within lymph nodes versus outside lymph nodes is also going to decide whether we are going to intervene or not. Small volume residual disease outside cervical lymph nodes, that means that there could have been an R1 resection or there is an aggressive early recurrence. So then we have to take an individualized call. Small volume distant metastasis need not be intervened unless they seem to progress. And large volume distant metastasis obviously need therapy. And this is another observational study which supports conservative management in biochemically incurable disease. So a study by Meckens et al. From Germany has, in a retrospective study, has seen that if the risk balance, benefit and risk is more in favor of risk if we just routinely reoperate on patients without selecting them, and repeat mediastinal lymph node dissection in palliation in recurrent medullary MTC is not going to help. So many studies have proven this same point. So I'll conclude by saying the latest thing is not just about measuring calcitonin and CEA. We also have to look at the doubling time. But as of now, we know that the less than a year, that is less than 6 months, patients who have doubling time less than 6 months have poor survival compared to the ones who have more than 2 years. But there are no standard recommendations that we have depending on this as far as the interventions are concerned. So points favoring observation, to summarize, are in biochemical persistent disease, is that challenges in defining the cure are there because the measurement of calcitonin is itself fraught, and variations in the literature in terms of definition and the studies have been there. And there's a change in outlook. In the past, there has been aggressive reoperations, regardless of the indicators, to current strategy of more conservative approach. And the indolent disease biology in majority of the patients of MTZ has to be identified. And if we are offering a treatment for persistent hypercalcitonaemia, is just to see that even the result is going to be the same, that is persistent biochemical disease, without actual change in cure rates or survival, then the risk is actually more than benefit. So we should not grope in the dark treating just the biochemical reports, and we should actually take into consideration the actual patient scenario. And just because we have a lot of options, treatment options these days, we should just not rush into using them, and we should use them very judiciously. Thank you.
Yeah, thank you, Ramya. So we'll go to the next speaker and then we'll ask you to speak again. Shall we? You could sit down too if you, because you want to see the slide. You could sit down to watch the slide. Yeah.
Now we invite the speaker again for speaking against the norm, Dr. Dhritiman, please.
Good morning, Chairperson. Good morning, guests, teachers, and colleagues. I'm going to speak about persistent hypercalcitonaemia and the role of interventions in such a situation. So, what are the factors influencing further management after the primary surgery? It depends on the extent of previous surgery. How much more can be done depends on how much has already been done. Significantly raised levels, a raised calcitonin level does not mean anything if it is not significant. Presence of symptoms in the patient, be it a recurrent nodule or a lump in the neck or systemic features, whether the recurrent disease is, we are being able to localize the disease or not, whether there is presence of metastasis and what is the extent of metastasis. And what was the intent of primary surgery? Was it a prophylactic, only thyroidectomy was done, or maybe a hemithyroidectomy was done and then MTC was detected incidentally, or whether a central compartment was done, lateral compartment wasn't done. So all these factors decide on how much further treatment we can offer the patient. So you can see the various extent of surgery and the amount of lymph node burden a patient may have, and in spite of removing all this, the patient may have persistent hypercalcitonemia, and you really don't know what to do. So why this debate? Because there's a common perception, and it's true also, that MTC is more or less an indolent disease, and asymptomatic residual or recurrent disease in spite of persistent hypercalcitonemia is not a matter of problem. However, several studies have proved that patients with more aggressive forms of MTC can have a rapidly progressive course, which is indicated by rapid calcitonin doubling time and appearance of symptoms. And one series from Mayo Clinic also reported a 66% mortality rate in node-positive patients with hereditary MTC after a median follow-up of 15.7 years. So, when something, such a high mortality rate is indicated by persistent hypercalcitonemia, then why not intervene? Why sit with folded hands? Now, there could be false high calcitonin levels in certain patients. It has been seen that there is mild persistent hypercalcitonemia after total thyroidectomy for PTC also. So there was this idea of stimulation tests with pentagastrin stimulation or calcium stimulation, and to rule out the falsely high calcitonin level, patients having falsely high calcitonin levels. But since pentagastrin has become unavailable in the United States, so they have removed it from all their major recommendations. Of more importance than persistent, absolute value of calcitonin is the doubling time. And there have been studies which have proved that patients with less than 6 months doubling time versus patients who have a doubling time between 6 months to 24 months, and those who have a doubling time of more than 2 years, they have a significantly different outcome. So definitely calcitonin is playing an important role in deciding what the prognosis is. So it may sometimes become the deciding factor about further management. Another study with 55 patients, it showed that calcitonin and CA, when they are concordant and are high in certain patients, they indicate in what proportion of those patients progressive disease can be expected. And this study recommends that both calcitonin and CA should be done. And we also know for a fact now that raised calcitonin may indicate that MTC is still differentiated. However, a low calcitonin with a raised CA may indicate a poorly differentiated disease. Now the NCCN guidelines, the current guidelines also state that if postoperative calcitonin levels are above 150, you do further imaging, try to localize the disease. If initially it is normal, but on repeat studies it is increasing, again you do a thorough check of the status of the patient, whether it is a locoregional disease. If it is a locoregional disease and which is operable, they're indicating surgical resection. They're not saying you observe the patient. Along with EBRT or IMRT, and with certain systemic therapeutic agents like vandatinib, cabozantinib, and now they have recommended, US FDA approval has come in 2020 for some drugs which are specific for RET mutation positive patients like selpercatinib and pralsetinib. And in poorly differentiated ones with raised CA, with a high tumor burden of more than 10 mutations per megabase, pembrolizumab, which is PD-1 antagonist, that has also been recommended. If there is distant metastasis which is asymptomatic, again all this systemic therapy can be used, and in symptomatic distant metastasis, they are saying that you can, they recommend using these systemic therapies as well as enrolling patients in clinical trials where radioimmunotherapy or PRRT based, lutetium-based PRRT have been tried, and they're also telling that you, even in palliative setting, you remove whatever metastasis is there. If it is amenable to surgical resection, do it to relieve the patient. So what is the prognostic value of persistent hypercalcitonemia? These studies have reported higher mortality rates for patients with high calcitonin levels, with more than 50% of patients having a recurrence during a mean follow-up of 10 years, which is not very long, taking into account the general perception about thyroid cancer. So TISL was the first person who gave this idea of microdissection, which means a thorough removal of residual nodal disease with a definite anatomical, within a definite anatomical boundary from the mastoid process down to the innominate vein and laterally, up to the level of spinal accessory nerve. He recommended that in certain cases we may have to add a median sternotomy. In today's age, people will add a VATS. Now, extensive dissection to remove all nodal and perinodal tissue from the neck and upper mediastinum was first reported to normalize the serum calcitonin levels in 4 out of 11 patients at least 2 years postoperatively by TISL. In subsequent larger studies by Molly JF and Fleming JB, there was about 20 to 40% of patients who underwent microdissection were biochemically cured, and there was minimal perioperative morbidity. When repeat surgery is indicated, obviously they also recommend a proper preoperative workup. Selective venous sampling to decide which side of the neck to explore again, or maybe whether there's a liver met and we need to remove which segment of the liver is involved, has been employed and has been found to be effective. Now, we have to be very clear about the intent of intervention. In certain patients, we would have to operate to relieve symptoms of compression or invasion of the trachea or major vessels. In some patients, it would be to remove a metastatic focus. Diagnostic laparoscopy, like in a case of suspected liver met, has been indicated in certain patients. Palliative tumor debulking procedures at different sites have also been recommended. Now, further studies were done on the outcomes of microdissection, and long-term results were quite favorable. 37 reoperations were done in 32 patients. In 28% patients, calcitonin was reduced to undetectable levels, and in an additional 42% of patients, calcitonin levels were decreased by 40% or more. Another study showed 45 patients who had reoperation with curative intent. The mean decrease in postoperative stimulated calcitonin levels was 73%, and in 86% patients, postoperative stimulated calcitonin levels were within the normal range or lower. Another study, 56 patients with 8 to 10 year follow-up data, 25 of them had normal or stable basal calcitonin levels after a repeat surgery. So, why would we not do a repeat surgery? Because we fear that there will be RLN palsy or hypoparathyroidism or a thoracic duct leak. But there have been comprehensive studies which have said that if you resort to a technique like a backdoor approach for a re-exploration, or if you use IONM and bipolar device, there has been acceptable rates of these complications, almost comparable to primary surgery in expert hands. Then the NCCN has come up with the various therapeutic interventions in the form of systemic agents. First being kinase inhibitors, vandetanib has been approved by the US FDA. Then we have carbozantinib, which has been approved by the US FDA. But they have said that there are some risks associated with bleeding and GI perforations and cardiac toxicity in these two. So we have to use it judiciously. Then RET inhibitors have been approved lately by the Libretto study and the ARROW study. Pembrolizumab I have already talked about. Anti-CA antibody-based radioimmunotherapy has been tried, though these studies have involved very less number of patients, but they have been found to be either equivocal or effective. Then PRRT using 177 lutetium-based octreotide and octreotide, that has been used, and again they have been found to be effective. And of course, in some studies it has been equivocal. Octreotide or long-acting octreotide for symptoms like diarrhea and bulky metastasis have been recommended in various studies. Coming to the ATA guidelines also, they're saying that if somebody has undergone a hemithyroidectomy, you should do and it has come out to be incidentally an MTC, you should go for a completion thyroidectomy. And regarding lymph nodes, if less than 5 nodes have been removed and the calcitonin level is less than 1000, indicating that there is no distant metastasis, you can do an extensive lymph node dissection. When you do lymph node dissection, this is the guideline that Ramya has already talked about. And they're saying that if you are doing lymph node dissection, please do a compartment-guided dissection and not just remove the enlarged nodes. The ATA guidelines for systemic therapy is pretty much the same as NCCN guidelines and also for, distant metastasis. So, except for the fact that ATA found dacarbazine-based chemotherapeutic regimens to be useless. So, I rest my case here because we find that with so many indications and scope of intervention in so many different settings, I would not sit with folded hands doing nothing, just observing the patient. Maybe a more experienced person is needed to be, practicing masterly in activity in such situations. Thank you.
Yeah. Okay, thank you. Ritiman, I'll ask Ramya to rebut, and then you could have an opportunity before I open it to the floor.
Thank you, Dr. Dritman, for bringing out the evidence for intervention. Actually, the study by Tissel et al. Has very less sample size, and at about the same time, the studies by Dr. Wells and Dr. Block and others have shown that observation also has, at about the same time, observation has similar outcomes, and in fact, in the study that you have quoted from Geoffroy Molle et al., there is only 28% biochemical cure rate. That means there are so many more, that is about 75 who have not been cured. And 40% reduction in calcitonin has no meaning, whether it is normal or not normal. That is what we are looking at. So as I said, persistent hypercalcitonin before start and same result after the start without actual extrapolation into increased survival is what they have observed. And it is not masterly inactivity, it is about selecting patients in whom we are going to intervene. As I said, just because we have modalities now, we should not just keep using them in anyone and anyone, but we have to select the patients. So that's what I was.
Thank you for that. You want to respond?
Yes. Thank you, Ramya. So actually, I think we come on a common ground when we conclude that we have to select our patients properly, and rather than a single value of calcitonin, the doubling rates are more important, and whether we are being able to localize any recurrent disease which can be taken care of surgically, or if a patient is symptomatic, maybe some agents to control the symptoms. So we have to select our patients carefully for whatever intervention we are planning to do.
Yeah, okay. So I'll open it to the floor. Any comments on observation versus intervention for hypercalcitonemia? Yeah. A mic, please.
We had operated a girl, a 16 years girl, with a total thyroidectomy and central compact dissection. Post-operatively, she continued to get hypercalcitonemia. The localization we found that was a small volume disease in the posterior chest wall close to one of the ribs, close to the vertebral column. It was a low volume disease. So she used to come every year to SGPGI for getting a scan. There was the tracer concentration in the same region. The serum calcitonin remained around 1,000 to 1,200, 300, 500, something like that range. She didn't get any progression of the disease. We have been following her. She is the sister of a medical student. So we have been following her, Dr. Pradhan and myself, following her for last about 7 years or so. The disease is confined to that particular site. So Anjali saw her, but she said that there was no indication for surgery because it is small volume disease remaining confined to a particular region without any progression. So these are the patients who have indolent, really indolent disease and need observation, and they hardly show any progression over time.
Sure. I think you've just proved the point that calcitonin doubling time is important. It's not one value. And if you've got stable values throughout, then you can just leave the patient alone. Any other comments? I'm going to ask for a show of hands. Yeah, so the mic is there.
We were one of the first to report medullary carcinoma in the country many, many years ago, and I have been following about 30, 40 patients over the years. And many of them have levels of calcitonin are very high. Some of them are symptomatic, some of them are not symptomatic. And one of the main problems many of them have is diarrhea. And we have to address that very often, and they have no other basic problems. So observation is an point, but when they have symptoms, like we have gone in patients who have obstructive symptoms, chest problems, we have gone in, done sternotomy, removed masses. So it's a hypercalcitonemia. Basic principle that I follow is don't treat only the biochemical value, treat if there are symptoms.
Yeah. Very valid point about don't treat a biochemical value, treat the symptom. And you need to weigh between the disease burden versus the airway and the morbidity of the, the loco-regional morbidity, which can be more damaging than the disease itself. So I'm going to just ask for a show of hands. Based on what you heard from the two of these speakers, where would you stand based on how would you go with hypercalcitonemia? Would you observe? Can I see hands for observation? Yeah, pretty much, okay. And hands. So can I assume that all the rest are going to be negative? Okay, I'm going to ask for hands for intervention.
Selective?
Selective
drugs.
Okay. So, yes, it's true, but I think the point, both of you brought your points across, but it's not one single value which is deciding. It is linear decision, and it's over longitudinal period of time which is going to make your call. And don't treat a value, treat the patient. And often you can have calcitonins in 20,000 and 30,000. The patient sirs mentioning, I know one patient who comes to me with a calcitonin of 20,000 every year. She has diarrhea, she has loperamide, and she lives life. She has an RT to the neck, and she's got plastered neck. We don't even bother to do a scan. So it just doesn't make any sense. And the point is, use of TKIs should not be conveyed in a persistent hypercalcitonemia setting. It is only meant for demonstrable disease which is not resectable. And that's when you bring in systemic therapies. Otherwise, it is investigation, identify the disease, and then treat accordingly. Okay, thank you to both the speakers. Well done and congratulations.
I thank both the speakers and Dr. Deepak for such an interactive debate. I'm sure all the points were made across very clearly. Now we'll be moving to the next session. It's a case discussion, initially the locally advanced and metastatic thyroid cancer. For this, may I invite Dr. Paul MJ to moderate the session. And for the first presenter, may I invite Dr. Priyanka Singh to present the case. I'll be inviting all the panelists one after the other, all the other presenters one after the other.
Okay, this session we are going to invite our colleagues from medical oncology, radiation, and as well as the endocrinology and genetics. So we have a good mix, and I hope interesting. So we're using the first case here as a starter, and then the discussions will be based on this. Thank you. Priyanka, go ahead.
Yes, sir. So good morning, everyone. So today I'll be presenting a case discussion over locally advanced thyroid carcinoma. So I'm giving you an overview. Yes, so here is 51-year-old lady who has presented with swelling in front of neck since 20 years and which has progressively increased in size since 8 years. She also had recent onset of dyspnea on lying down, and she complained of new onset of swelling over sternum since 3 months. She also complained of left arm pain and weakness. She had change of voice quality, however no hoarseness, but she had a stridor on deep inspiration. On local examination, there was a large diffuse multinodular goiter and with the dilated vessels over the surface and in pre-sternal region. There was also one swelling which was around 5 into 7 centimeter over sternum, which was pulsatile and bony hard in consistency. Now coming to the differential diagnosis, differential diagnosis was carcinoma thyroid with bony metastasis. Now question is whether it is a well differentiated or poorly differentiated thyroid carcinoma. So as a part of preoperative assessment, so TSH we have done, it was suppressed. Free T4 was 0.43 and T3 was elevated. TG was in a quite high range. So we did vocal cord assessment, and our first NPLScopy showed that there was a left vocal cord palsy. However, second, there was a bilateral mobile vocal cord. So question was whether there is a nerve infiltration with the fluctuation of function. So this patient, her interpretation of her functional status, she was having T3 toxicosis. And she was having palpitation, which was managed with adding propranolol as a part of preoperative management. So we went ahead with the imaging, and so we did ultrasound neck, and contrast CT was done, neck and thorax, and MRI of spine was done. So we can see in this, this is chest X-ray in erect position, and we can see this radio-dense swelling in front of neck, thyroid swelling, and with a chunky calcification you can see posteriorly, and there is a deviation of trachea and with a compression of lumen. Now this is the CECT picture of neck in axial view, and you can see there is a heterogeneous density of thyroid swelling, and there is a hypodense area, could be necrotic area. And also there are multiple dilated veins over the surface, and calcifications are also present. And this tracheal lumen is compressed, and also esophagus is not visualized clearly here. And this, on the left side, we can see this IJV is stretched out over the surface. However, the carotid is free. Now coming to the MRI spine. So you can see here thyroid swelling and sternal metastasis, and posteriorly there was a lytic lesion in C7 vertebra which was extending to C6. Now what would be our plan of management? So we had two-stage procedure was planned for this patient. So in the first stage, we have planned thyroidectomy, tracheostomy, and excision of sternal mets, and excision of C6 corpectomy via an anterior approach, and its fixation by using implant, that is plating, was done for this patient. Now the second stage, we have planned posterior approach to C6 spine excision of residual tumor and fixation. So you can see this patient nasal intubation was done, fiber optic intubation we have used, and in this rose position patient is lying down, and you can see this thyroid swelling with the dilated vessels, and also sternal metastasis is seen here. Now this is intubated patients. So intraoperatively, and this RLN nerve on the right side was stretched over thyroid, and was stretched over the thyroid swelling, and we have tried to save the right side recurrent laryngeal nerve because left side was doubtful. Now this is the after resection of the specimen. This was our resected specimen of thyroid swelling. So, tracheostomy was not done in a stage 1 procedure because there was a high risk of mediastinal infection. And so after 2 stages, the post-op extubation was failed, and could be because of the nerve injury during endocrine or thoracic or neuro procedure. So tracheostomy was done to maintain the airway. Now, as I told, second procedure was through posterior approach, the laminectomy was done, and the patient was advised hard collar support for 6 months. Now, histopathology reports showed there were a nest of closely arranged follicles lined by cuboidal to columnar cells with abundant granular eosinophilic to vacuolated cytoplasm. Nuclear enlargement was present. There was capsular and vascular invasion. So final diagnosis was Hürthle cell carcinoma involving both lobes and isthmus of thyroid. Size was 12.6 centimeter. There was capsular and vascular invasion, and also extrathyroidal extension was present. There was 2 central node adjacent to thyroid, which was reactive with the reactive changes and free of tumor. Separately sent sternal mass was with metastatic tumor, and also the spinal lesion which we have sent showed the metastasis, thyroid metastasis to the lesion. Now, this is the post-op picture of patient where patient is sitting comfortably with the tracheostomy tube here, and we can see here hard collar is applied to over the neck. Now, regarding, so after surgery, we have planned her for adjuvant treatment, and she was given RT to spine was given 30 gray and in 10 fraction. Following which we have done whole body scan where it showed there was a residual thyroid disease and also a bone and lung mets. So we have ablated it, and patient was put on suppressive dose of thyroxine, and patient was followed up further. So role of RT in thyroid cancer, it could be adjuvant where we have done the R2 resections and patients, with a high risk features. With a palliative intent in case of symptomatic metastatic disease. And neoadjuvant has role in anaplastic carcinoma. And MDT is very compulsory before planning for RT. Conformal RT technique, it provides better quality of life to patients. And this will be discussed in further session in detail. Now we did this TG, we can see here, the sequence of TG, it is coming down. So it is decreasing in trend. And there is a significant improvement after post-therapy scan in November 2018 when we repeated the whole body scan. Now this role of systemic therapy in differentiated thyroid carcinoma will be discussed in detail by Dr. Divya. So we can see this patient on follow-up, she is comfortable and with a tracheostomy tube. So at the end, in July 2021, on follow-up, she had the symptoms of brain mets, and the MRI showed there was a brain metastasis of 2.3 into 2.6 centimeter, and she was planned for whole brain RT at her hometown. So take-home messages are that differentiated thyroid carcinoma with skeletal metastasis or locoregional involvement needs a multidisciplinary treatment approach. Resection of bony metastasis can be done for curative intent or palliation of symptoms or to facilitate iodine ablation. And treatment has to be individualized. Thank you.
Thank you. This is an interesting case. This is 2017 when she came, and it throws up a lot of issues. Initially, about how to manage the bone metastasis, doing a combined dissection with neurosurgery and thoracic for the sternum as well as the spine. We, as far as possible, we do it combined. If the teams coordinated, it can be done, and as was done in this case. The second issue was about having a tracheostomy when you have such a large sternal excision. Now, the thoracic surgeons are not happy with the tracheostomy in the presence of sternal cut because they say the possibility of osteomyelitis is high. So the third issue here was when we extubated her finally, the right recurrent actually was not seen, and the left, which we preserved, was not functioning. So obviously, this throws up the issue. Maybe if we had neuromonitoring at that time, it may have helped. So it must have been an intraoperative injury. And in fact, when we took her back to theater to convert to a tracheostomy, we had a very bizarre experience that when we put in the tracheostomy, the ENT surgeon was also there, we couldn't ventilate the patient even with the tracheostomy in situ. When we put a bronchoscope down, we found that the intrathoracic component of the trachea was actually tracheomalacic, and it was collapsing. So even with a tracheostomy in situ, we couldn't ventilate, so we emergency had to just take it out intraop and use an endotracheal tube to go right down to the tracheal bifurcation. Only then we could ventilate her. So we used a special tracheostomy with a long segment intrathoracic, which then was what she was using. Then the follow-up, I think she may not have survived even that year when she came with that disease. So the good point is she got 5 years, and now last year we realized she had a brain met. She's following the RT. We don't have further review. So these are all the points earlier for discussion. Is anybody would like to make any comments? Yes, Dr. Arvindan. It is reduced, sir. Not it's a 40%. I think is the uptake in Hertel. Yes, Dr. Amit.
So, interesting case, but not to criticize, but 10 years back I would have done the same management, but over the years I've realized these are not solitary metastases. So I've stopped doing excisions for sternal. I did maybe 5 or 10 cases 10 years back, but as the bone scan later on showed that she had multiple metastases, or radioiodine scan showed lung and bone metastases. So do you think you achieved anything by excision of the sternum? Just as a matter of discussion, you know. So because these are not solitary metastases, once you do a radioiodine scan, you realize that there are multiple metastases, and excising one is not going to really make a difference. And perhaps a PET scan, early PET scan, in cases like Hurtl cell or aggressive locally advanced, is more useful to guide further management. You know. The other point is our pulmonologists perhaps nowadays would stent it rather than, you know, do a permanent tracheostomy. So if there's a tracheomalacia down there, probably they can do a bronchoscopy and put a stent which can palliate the patients. So these are some of the points I thought I'll share. Yeah.
So my wife being a pulmonologist, I know a little bit more about this, but they don't stent for diseases unless
long
they are
segment,
sure.
yeah.
They
It's
are
too
sure.
long a segment.
Yeah. So actually, one thing I wanted to know is like that you showed the thyroglobulin levels. It fell from 14,000 to 2,500. Then suddenly it fell to 50.
It started with 1,47,000. That's
Yeah.
okay. 1,47,000 and came down to 50 at the last follow-up.
Yeah, but there was a 2,500 and a 50. So would you think that this has gone into a de-differentiation and would have gone a PET CT at that point of time itself to look for this brain mets and started a TKI for her?
Yeah, but again, that's the whole point of TKI. Actually, following the initial operation, apart from the tracheostomy tube, she was fine. She was fully functional, walking, doing all her stuff, climbing, uphill, and she was extremely happy with her outcome. And the only problem happened when she had the brain met with the headache. So that was in 2021. So okay. It's your call.
The spine, who fixed, the neurosurgeon or the...
Yeah, and that will introduce me to the next speaker. Thank you. Sit down.
Thank you.
So we have the next speaker, Dr. Krishna Prabhu. We're very happy to have our neurosurgery head, who is a colleague right from hostel days. And I must pay special thanks to the team who are very proactive, I should say, on treating these spinal mets. And we have just compiled the series of spinal met excisions, and we're hoping that it will be published soon, and you can see that possibly we need to be more aggressive with these bone diseases. And I ask Krishna Prabhu now to take us through the approach to these thyroid mets to spine.
Thank you, Paul. First of all, I want to thank Paul for inviting me to give this talk. A warm good morning to everyone. A special good morning to Dr. Arvind Nair, who's my teacher, who 31 years ago taught me about thyroid. And I still remember 1991, he took clinics, a patient with thyroid with spine meds. So he was telling us that, after surgery, he will send him directly for radiation therapy because he's having severe pain. So anyway, 31 years down the line, let's see where we are now. So thyroid meds, so my question is to operate or not to operate? Where do we go? So basically, if you look around, metastatic tumor to spine is quite common. Thyroid meds is also pretty common to spine. If you look at the overall in the spine metastasis, thyroid alone costs around 3 to 4%. We have other things which cause much more metastasis, but thyroid does form a significant number. Most commonly, it involves the thoracic spine, then followed by lumbar spine, followed by cervical spine. If you look at the pathology, extradural pathology is about 95%. That is basically pure arising from the bone and soft tissue around it. Intradural per se, it's very, very low. It's less than 5%. So the pathophysiology of any other metastatic tumor, it depends on basically on the metastatic property of the primary neoplasm as well as anatomic and biological properties of the skeletal host. Now, when there is a metastasis to the spine, usually the posterior half of the body is involved first, and then the anterior half, the pedicle and lateral mass all involved later days. And they always spread to the adjacent vertebra and adjacent vertebra, and also epidural space. They cause both in osteoblastic as well as lytic lesions, and the narrow gets replaced with neoplasm. This is the general pathophysiology of all metastatic lesions. The most common presentation is pain. Almost everybody will have pain. There's unlikely you'll find anybody without a pain. Pain is the main thing. It could be centralized, constant, radicular pain, sometimes axial pain. They may be associated with the deformities, neurological deficits, and of course associated constitutional symptoms of metastatic diseases. So the red flag here is that if there is a patient who has got suspected to have spinal mets, if he has a gradual onset, progressive pain, more at night, more at sleeping time, more at lying time, then start thinking that there is something wrong and get him evaluated. So of course, the age-old thing, history, examination, lab studies, and followed by imaging studies. That's how we go about it. So when you come to the imaging studies, a plain X-ray it's mandatory. We still have not gone away from that. Plain X-ray is mandatory, and it will give you a lot of information. We do a bone scans, we do CT scans, we do MRI, and in almost all of them, we do also do a CT PET scan to look for other metastases to decide about how we are going to approach this patient. So if a patient comes to me with unknown, then I will evaluate, and if I find the primary, I will get the primary physician or surgeon who was involved and then take the plan. If I don't have any primary, then I directly will deal with the lesion, either whatever, biopsy, surgery, decompression, whatever, get the tissue diagnosis and get the primary surgeon or physician involved in the treatment process. We always do a bone scan because I want to know whether it's involved in a single vertebral body or multiple vertebral bodies, and that tells us whether to go for biopsy or whether to go for stabilization. So the combinations of that, whether to observe and wait, to call for other help. So we need to do a bone scan before we proceed with any further treatment. And of course, biopsy will be with him. So as I mentioned, the plain X-ray is very, very useful. Anybody can read it. You don't need even a radiologist to give you a guide. You can read it. There are 4 things which I want to say. One is what I call is the winking owl sign. If you can look at the pedicle in the AP X-ray, on the first image, you can see that on the right side, the eye is open, but the left is closed. That means the pedicle is destroyed. That's a sure sign that there is a metastatic disease. It's called a winking owl sign. It's very easy to pick it up in a plain X-ray. Then also you can look for collapses of the body, destruction, paravertebral shadows. So those will give an idea that whether there is a metastasis or not before you go for costlier and more invasive tests. Bone scan, of course, it's mandatory that we do, without which we will not proceed, because it tells, it's superior sensitivity, and it tells about the extent of dissemination. It also tells where we can get the chance of getting a biopsy, the yield is where is much better. So the site can be chosen from this. So that's another way it helps us. CT is almost necessary because CT gives a good anatomical, the destruction caused by the lesion. You got a much better orientation with the CT. So the bony anatomies are always seen better with the CT scan. And it also tells us the surgical plan, helps us in the surgical planning. MRI is always mandatory because the bony lesions you will get from CT, but all the soft tissue involvement you will only get from the MRI scan. So an MRI with the GADO, it's mandatory. So an MRI, a GADO, a bone scan, and X-ray it's a must. I mean, you cannot do no shortcuts in this. A PET scan, of course, will tell you whether there is going to be other lesions, which is going to decide your way of management. It also will help us if you want to do a recurrence. Suppose you have treated, and if you want to know if there's a recurrence, a local recurrence, a PET scan will be very useful to us. Also, sometimes in elderly people, it will tell us to differentiate whether it's a metastatic fracture or is it an osteoporotic fracture. So if you have a doubt, that will also help us. So CT PET it does helps in many ways. So biopsy, there are different types. I'm not going to go into it. Percutaneous approach biopsy, we can decide the level, and basically accordingly we can do either sometimes with the fluoroscopy guided, CT guided, sometimes open biopsy also we can do it. So when I have a patient with a thyroid with a METS, the treatment has to be directed to primary first. I mean, you have to handle the primary disease. Without handling it, I'm not going to do anything, cure the patient. I mean, I may help the patient temporarily with the stabilization, decompression thing, but the primary has to be treated, without which I'm not going to go and operate this patient or stabilize. You also then direct to a spinal lesion. So I would just go through what are the past and present state of how we manage metastatic spine and how we have a model which we feel is maybe a useful model. So if you go the old, historically, what they do is they will always go for laminectomy and laminectomy was the main surgery and then followed by RT, which in those era, there was no much of spinal instrumentation. The spinal surgery was very, baby stage, and then now we have gone a long way where we can take the entire disease, entire clearance of disease and stabilize this patient. So the earlier ways of doing just a laminectomy and radiation therapy, it did not do much. Of course, it gave pain relief, it gave some quality of life, but not anything great. So this is what I said. So it gave pain relief, ambulation, and some amount of improvement, but it did not prolong or the life expectancy or did not give a much better quality of life because we were limited. Then in the last 20, 25 years, there has been a lot of shift, and now we have come with, we're able to do much wider decompression, a gross total excision of the tumor itself, followed by a stabilization procedures. So this kind of surgeries definitely help in reduction of the pain, also an early ambulation, definitely it maintains a good quality of life. But you have to choose your thing because it does not always tell you that your survival is going to increase because of this. So you have to choose which patient is going to benefit from this. If you have a patient who's got multiple meds and you do all this, suppose and just single meds of the spine, you may do all this, but it may leave a fair amount of good quality of life, but it may not prolong his overall survival rate. So that we have to be in consideration while making decisions. Okay, so the way we go about this analgesics we also do use bisphosphonates in some cases. Whenever a patient comes with pain with some amount of deficits, please start on steroids before referring to a spine surgeon because they definitely will help the pain relief and also some amount of neurological improvement will happen before the surgery itself. So we always start steroids at high dose. Sometimes we directly upfront send the patient for radiation, not for surgery. If it's a radiosensitive tumor and we know that and they don't have much time, a patient is not fit for surgery. If there is a progressive neurological deficit and there is no instability and if surgery is contraindicated as multiple diseases, then we directly upfront we send them for radiation therapy. We do not suggest any surgical procedures. So they can go with various things. With my subsequent speakers will speak about the modalities of radiation. What we can do sometime is, if it's not going to be a curative lesion, we can offer a palliative lesion. So one of them is a vertebroplasty. What we do, suppose a single disease metastasis, we inject bone cement into the disease body. It will relieve pain, it will stabilize to some extent, and PMMA is also known to have some amount of anti-tumor activity. So the pain relief and stabilization can be you can achieve with vertebroplasty, especially in those who cannot do a surgery or those who want to delay surgery for some reason or other. Because this can be done in a fluoroscopy room in the radiology department itself. It's a daycare procedure. Because they take care of the microfractures, so the pain relief is immediate. We also do something known as a kyphoplasty, which is the next advanced level of vertebroplasty, which is more or less the same, except that it also restores the height, and you can put more bone cement into it, and it increases the vertebral solid strength much more than a vertebroplasty. It's a little more costly, but it has a little more advantage to the vertebroplasty. We also do use radiofrequency ablation. I have not used personally much, but it's been known that people do use it for pain reliefs. So if I decided it's not to go for surgery, so my aim, the goal of my surgery is to get tissue diagnosis, to decompress and stabilize. This is my goals. Resection, decompression, stabilization. So these are the indications that we will go for it. So when you make the decision for surgery, these 4 columns should be always tumor, where is it from, how many tumors, what is the clinical presentation, what is the estimate of longevity, and what is the stability is going to offer. So these 4 parameters should be considered before you proceed with any surgical procedures. We use 2 scoring systems. One is, of course, Konofsky, everybody is familiar with it, Tokuhashi's index. And this is the modified score where we look at the Konofsky score, extraspinal metastasis, spinal metastasis, bone metastasis, other metastasis, and the source, where is it from, and spinal cord deficits. So based on this, we we can make a life expectancy. If it's 0 to 4 is less than 3 months, and if it's 9 and 12 is more than 6 months. So higher the score, so the score that depends on life expectancy. Also, you have to make your surgical plans and treatment plans. This is the Tomita classification, where it's basically a surgical classification to decide how much bone to remove, where to remove, how to approach the patients. This is the Tomita classification. It divides into multiple compartments, and it depends on the compartment involved. We approach the lesion, and we try. Our aim is to try and gross totally remove as much as tumor as possible. If it's one body, if it requires the whole entire vertebra to be resected, we will resect all 360 degrees and then reconstruct it. Based on this, I told you again already. So as I mentioned to you, so if you look at here, the zones are called 3 zones. The zone 1 and 2 is the posterior half. So if disease is predominantly posterior, then we'll approach posteriorly. If it's zone 3, which is anterior, then we go anterior. And if it's the middle, which is zone 4, which is we do anterior and posterior combined. But this was the thing we followed from maybe 20 years ago. Now we can remove the entire body from behind. We don't need to do any thoracotomy, no laparotomies. I can remove the entire 360 degree of bone from the behind. We can go around the cord and remove it and reconstruct it. So these are some of the examples I know, but after decompression, extensive instrumentation is required. So like this patient had a 360 removal of the body was removed, and we were able to put a cage in front of the cord. You can see the Durant, the cord, the cage has been pushed from the sideways, and you stabilize with the pedicle screws. And all these people, so you can see some examples. You can see a posterior and middle column involvement. We were able to remove from behind, cage is put, and screws have been placed, and patient is doing well. It's another case, done from behind, cage placement, then done well, patient done well. This patient got also done from behind. So we stopped doing anything from thoracotomy, laparotomies, we don't do at all. Everything can be done from behind. One stage you can do, it saves a lot of time, money, blood loss, and patient also do very well with that. This is cervical, we did anterior disease, so anterior approach was done. This is another patient who had a disease with the kyphosis, we corrected it. So where did we come, where are we going? Yes, now we have come a long way, surgical techniques have improved, our outcomes are better, we are able to do the surgery, discharge the patient in 48 to 72 hours, and they do a good, better outcome. So we have got about 44 patients with spinal mets from thyroid in our series. Hopefully we'll just come out. This is analysis, we're just finishing it. This is the preliminary analysis, I've just put up some of them. So out of the 44 thyroid mets we had to spine, we had 18 patients underwent surgery, and the remaining 26 were managed with other modes of treatment. We did not operate at the thing. So if you look at the mean overall survival rate is around 96 months, and the progression-free survival was 67 months. It's pretty good. It's better than even the other statistics published from other centers. And in the non-operative group, again, mean overall group survival was 82 and PFS was around 51 months. So if you look at the age, less than 58 and more than 58, we have the numbers. If you find here that actually the more than 58 group has got a better progression-free and everything. So the only way I could explain this is maybe the younger people who came with a more aggressive disease. Could have been that is the reason they are having a much lesser progression-free or survival rate. If you look at the with Kaplan-Meier curve, I can show that with surgery, obviously it's much better. So yes, definitely single metastasis, yes, we can, solitary metastasis to spine, yes, we can do a good excision, decompression and stabilization. Multiple mets, yes, we can only offer some palliative therapy and the thing. And I think ultimately the outcome is going to depend on the primary disease, primary care, and depends on other metastases. So my goal as a spine surgeon, it's not a cure for the disease. Of course, cure for the local disease, but not as the disease of whole disease. Definitely you need multidisciplinary and surgery or radiotherapy, both is hand in hand. And management is still, there are some areas which we are not sure, some areas. Anyway, time is running out. Thank you very much.
Thank you, Dr. Krishna Prabhu. Any comments from the floor? Yes, Siddharth.
Thank you, sir. Excellent talk and an eye-opener for most of us, I think. I was thinking whenever disease spreads to the spine, we won't be able to take out the entire tumor and some tumor is left behind, which we have to address it with radiation. So my question is, if we are able to take out the entire body and the entire tumor of the well-differentiated thyroid carcinoma in that particular area is out, do we have to give radiation?
Yeah, I still feel we should give focal radiation. One thing is we can do a PET scan to CT PET to see if there's any residual tumor which I left behind, some soft tissue or not. But I would still feel you should give it.
We should give.
It's my I feel. If you have done it, I would give it because that will definitely do a better thing. At least a focal radiation can be given to it. You know.
Thank you, sir. Thanks.
Thank you. Yes.
Regarding this particular patient that was presented with the spine metastasis at the cervical spine and a rose position, would you have preferred fixing the spine before the thyroidectomy?
No, what we thought here is we are anyway making a big incision anterior, and the spine is accessible, so we did it directly anterior. You already got an open.
Okay. Yeah. But this one is anyway we had done huge incisions. We could do it from behind.
Here there was no roads. It is because the whole thing was just occupied, just flat.
See, we had he knows that Paul knows that 4 days ago we had one patient. A lady came to my OPD actually with the cauda equina syndrome, and we found that there was a metastatic lesion at the L2 thing. And we also found that she has a huge thyroid. So we sent them to them, and I told them to do the surgery. Last Friday, I think they did the surgery. They removed the whole thyroid, and yesterday we turned around, we got the whole thing from behind, and we took it out. So I would prefer thyroid to be done first, and then take it from there.
Yeah, no, his points about the access, but you understand, because we were going from the front anyway, we did it. In fact, they were thinking initially they'll have to go both from the front and the back, but they managed the whole thing from the front. So in one procedure it was done. Yeah, thank you. So we have these stories of patients coming in a wheelchair and then walking home. So it's really amazing when we see that. And they have good, reasonable survival of quality life. I think we are not aiming to cure.
I compared the data, our data with the existing data, and actually it's very good.
Okay.
It's much better than many centers our rates have come out. We're still doing some more sub-analysis. Hopefully we'll publish it soon. See, if it's, one continuous means I can remove 2 at least. I can put a cage and then fix it. But if there are multiple, then even multiple surgeries are required.
In one segment, 2 bodies you can replace.
Ideally 1.
Ideally
but
1.
2 I can take if you want another thing. Because what happens is the blood loss is what we are a little concerned. So the anesthetist has to be ready with it.
This last question, Dr. Ranjit.
Actually, when you have a multi-system involvement like this, and you have a spine met, you want to follow up these patients. So you said zone 1, zone 2, and zone 3. So would you prefer to intervene immediately if it is in zone 2 and zone 3, and zone 1 you just look for progression of disease and then go ahead? Or what criteria you use for this? Do you use RECIST criteria? What do you use for this progression of disease?
If the primary is addressed, and if I find anywhere, whether zone 1, zone 2, zone 3, I will address immediate. I will not wait and follow up. I don't find any reason why we should follow up, because it's not going to disappear. It's going to only make troubles for us. So there's not going to regress, it's not going to disappear unless you're treating with something. So I will not, if you're going to just follow up after thyroidectomy, no, definitely not acceptable. Wherever it is, because it doesn't matter, zone 2, anything can be removed. Or some treatment should be given.
The problem is like our neurosurgeons, convincing our neurosurgeons to operate on a metastatic disease.
Yes.
It is a really tough job. So if there is some way we can say that this is going to have a problem now. So
please send your presentation to him. Forward it to your neurosurgeon. Okay, thank you.
I think you should tell them that, it's not that it's not, 20 years ago is different, now it is different. We have got many stories to tell, and we have very firm belief. If the primary is addressed, then I have no reason not to intervene. If not addressed, then I have my reservations. If it's addressed, it doesn't matter, zone 1, zone 2, and zone 3. Because nowadays we do this procedure, it's only about 2 hours from the back. We put screws and take the whole body out in 2 hours and out. In the first, when I did about, say, 12 years ago, we used to take about 6 hours. Now 2 hours are doing, and even the juniors are now doing it in 3 hours later. The minimal invasive, I can do screws and decompress the lamina, but I can't do a 360-degree thing, because for that, I have to remove the head of rib and go around, push the pleura down and go around and take it out. So that I cannot do. We are not ready yet. Let's see.
Thank you. I think this topic is a big hand for Krishna Prabhu, and thank you for all your work. Thank you. We'll move on to the next speaker.
Thank you, sir, for such a nice talk. I think a lot of us have a lot of questions answered now. Now we'll move to the next topic, approach to radiation therapy for thyroid cancer, state of art. May I invite Dr. Balu Krishna, sir, to do the talk on that.
Dr. Balu is a professor in the Department of Radiation Oncology, and they've also undergone a lot of changes in the way, as you know, of delivering radiation. He'll tell us about our current state.
Yeah, thank you, Dr. Paul, Chair. Happy to see Dr. Nair. You have indirectly taught us quite a lot through our common interactions and MDTs. Senior faculty from across the country, friends, Pooja, hi. So, and all surgeons across the country, very good morning to you. I've been given the task of talking to you about radiation therapy in thyroid cancer, which has been mentioned quite a number of times in the last 1.5 hours. And I am asked to focus on what is state of the art. So let me just in the next 20 minutes tell you briefly whom and when we would offer external beam radiotherapy in various situations and how much are we giving. And also, I would focus on what is state of the art. So before I begin, a few facts. We also accept that surgery is the mainstay in the management of any kind of thyroid cancer. We expect you to remove it in toto with all the nodes and leave as little disease as possible. Radioactive iodine is an excellent follow-up therapy to clear up the microscopic disease, and that too with very less toxicity. And we also say that EBRT works, but there are a few things that we need to understand. First of all, there is always a misconception that radiation burns tumors and kill and all. No, it is an ionizing radiation. When it passes through a region of tumor, it induces DNA breaks in the cells, in all cells, whichever it passes through. And the cancer cells, because it multiplies fast and it is undifferentiated or less mature, they are driven into a programmed cell death or apoptosis, while the normal cells recover from this damage. So that is what we use to actually kill these cells, any kind of cancer cells, with fractionated radiotherapy. And we also have to understand that a more differentiated cell will be resistant to radiation, while a poorly differentiated, faster multiplying cell will be easier to kill with radiation. So along with that, I would also like to tell you that after surgery, which is a commonest scenario that we are called in to give radiation, there is a lot of remodeling, repair, and healing happening. There is recruitment of cells. At that point, when we give radiation, this process becomes delayed and the healing ends up having fibrosis. So we did mention about plastered neck earlier. So that is one issue that happens because of radiation coming in right after an extensive surgery. So that causes the late side effects. We generally delay radiation to up to 6 weeks after surgery to let all the healing happen to reduce these side effects. So to begin, the thyroid cancers can be actually classified into the good, bad, and the ugly, which you will very well know. The good ones, the well-differentiated ones with a less mortality, less than 5% in 5 years, to the anaplastic ones, wherein less than 10% survive to 5 years. So within that, the target of external beam radiotherapy can be either a primary, which is definitive radiotherapy. We don't use the term neoadjuvant in thyroid cancers. Tumor bed or adjuvant radiation, which is the commonest indication or the referral that we get, and also the metastatic disease. So in this context, I will explain. So when we speak about external beam radiotherapy to the primary disease, that is mostly in a scenario of this ugly histology, which is the anaplastic cancer. We are often called in when the patient presents with a large tumor compromising luminal structures and needs emergency intervention, and surgeon says, I cannot debulk this, why don't you do something? This is mostly an aggressive palliation because less than 10% patients live up to 1 year even with the best therapy. The radiation doses are quite high, and we would recommend concurrent chemotherapy with it, but if only a handful of patients, if I remember, would have received concurrent chemo because they generally are not fit in this particular disease status. So this is the radiation when the primary is not operated out. So that is also established in various guidelines. So what about the post-op setting? That these are the bad tumors. That is either the poor histology or a bad T stage. That is, the surgeon could not remove the entire tumor and a bit of gross disease remains behind. At that point, we are called in to give external beam radiotherapy. And most common indication that we find that we are called in is when there is a tracheal invasion or a tracheal resection has happened. A residual tumor being there or an R2 resection, and a recurrence can actually compromise the critical structures. So this can happen for laryngeal invasion, tracheal invasion, esophageal invasion, etc. And RT, external beam RT, does have an excellent local control benefit. Then the good tumors or the presumed good tumors, or the previously they were good and now it has turned bad. So this is a situation where we employ radioactive iodine, but iodine is not working. It can be at the time of initial diagnosis itself where there is no uptake, or when a recurrence is happening which is not showing iodine uptake, or a metastasis which is not showing uptake, or the patient has gone through the entire series of iodine therapy and finally cumulative maximum has achieved and they cannot give anymore, and at that point radiotherapy can be called in. Or in metastatic setting, or in dedifferentiated tumors as mentioned earlier, where an FDG PET will light up the disease, and if it is localized, EBRT can be given. So how much to give? So I told you about the scenario where and whom and when we will give. How much to give? Generally, in a gross disease setting, we want to give up to 70 gray in conventional fractionation. This goes on to a period of 7 weeks of radiotherapy. This is similar to what we do in other head and neck cancers, squamous cell carcinomas. If the tumor is completely removed and only microscopic disease is expected, we limit to 60 gray. And palliative doses are lesser. So when I say how much, it also means the volume of the body that we are treating, and what you see in this picture is how much we would treat in an extensive thyroid cancer where there is lymph node mets. We will treat from level 2 to even include the anterior mediastinum, especially in case of medullary carcinoma thyroid when we are called in. So it's a very large volume that is getting treated with a very large dose, and hence there is toxicity, and hence I said that it has to be chosen for the right patient. So that is the list of toxicities that we expect. There is a lot of acute toxicity as well as late toxicities. Late toxicities, most often we have seen in the earlier era when we didn't have such high-end technologies. But even with high-end technologies, as I said, a post-op radiotherapy does carry toxicity, and it has to be chosen wisely. So now come to the main part of the presentation, that is what is state of the art, the evolution of radiotherapy technology. So I've been in radiation oncology since 2004, and I've seen the evolution when we were, with respect to thyroid cancer, 2004 to 2010, we've been using conventional radiation for that. Then we moved on to 3D CRT, then IMRT and VMAT, and currently we have tomotherapy and SBRT. So I've seen the entire spectrum of evolution that has happened in thyroid cancer, and I'll try to explain that to you. So conventional radiotherapy, we don't offer conventional radiation to our patients because if I look back to what we have done with conventional RT for these patients, it is suboptimal. So we would try to arrange resources to give conformal radiation to any patient, which is the standard of care now. But conventional has been cheap and simple. It used to do its work, but with higher toxicity. It is simple X-ray based planning. And I just, when I looked up for this presentation, I saw my older presentation, which was done in 2008 about thyroid RT. And I found this was the fields that were used. So this is a contour of the neck. We just use X-rays and simple contouring. And these are two representative beams, one from front and one from behind. And these were used to actually radiate the entire area as I have shown before. we also used to improvise with that. We had electron beams. So if the tolerance of the spine has reached, we used electron beams. We used to use oblique beams, and we used to use mixed techniques. But this is the best we could do with conventional radiation, but not reach the desired dose, as well as, but we would end up with higher toxicity also. So then in 2008 to 12, we moved on to 3D CRT. That's because this multi-leaf collimator. This is the head of a older LINAC that we had, which had multi-leaf collimator, which enables us to actually shape the beam based on the, and it was a CT-based planning. From X-ray, we moved on to CT and linear accelerators, which had beam shaping abilities. So in the direction of the beam, we were able to actually shape the beam to the shape of the tumor. So which we call the beam's eye view, which actually helped us to conform the treatment to the tumor. A little better than what was happening before. So that was called 3D CRT, and the enabling of CT-based plans, which help us to actually draw the target slice by slice, get a three-dimensional view of it, and then radiate the tumor bed. So that was the advancement that happened from 2008 to 12. Then came in intensity modulated radiotherapy, which is basically an advancement on 3D CRT, wherein along with shaping of the beams, the multi-leaf collimators, as I showed you, were able to also adjust the intensity of the cross-section of the beam, so that we can give more dose to areas where there is a higher density of tumor and less dose to areas with lesser density of tumor. So that helped us to actually sculpt the dose to the target and spare as much normal tissue as possible. So this now became the standard of care for thyroid cancer because the toxicity reduction was quite high. And we also employ a technique called inverse planning, because based on the imaging and target, earlier we used to actually decide the beams and prescribe. Here we prescribe first, and the computer, based on algorithms, will actually give us the desired plan. So that was also an advancement because we could spare a lot of normal tissue here. Then a technology developed further. In 2016, we acquired the rapid arc or the VMAT technique, wherein the conventional IMRTs, the beams, though the beam is modulated in intensity, the gantry, which is this direction of the beam, that remains static for each beam. But in VMAT, we are able to actually treat while this goes around the patient. So that gives us much more permutations and combinations. Like this is the calculation. So the entire, from all around, we should be able to treat with smaller beamlets and get much better distribution, a faster treatment delivery. Treatments which used to take 15 minutes for a 2-grade delivery gets over within 5 minutes. So it became much more precise and much more quality of radiotherapy improved with VMAT, and we employ this for all our patients as of now. Along with that, you also would have heard of the term image-guided radiotherapy. Image guidance is not replacing IMRT or VMAT. It is an addition to IMRT and VMAT. Though we plan radiotherapy on the computer, we also have to make sure that the right radiotherapy goes to the right target. So to enable that, we have imaging within the machine, so that each fraction, before each fraction of radiotherapy, we have a CT scan done, which will be overlaid with the baseline CT scan, as you see in this picture. And we have a 6-degree motion in the couch, which will actually correct for it. And we actually, currently we achieve an accuracy of 3 millimeter to the desired target to deliver our radiotherapy. So that is image guidance. So image guidance is added to the VMAT or IMRT that we employ. So this, further to that, what happens in thyroid cancer, the treatment is for 6 to 8 weeks. During this period, because the tissue, there is a lot of edema after surgery, which will reduce, the patient may lose weight. Lot of temporal changes happen, and we need to adapt to that. So that workflow is called adaptive radiotherapy, which also we employ in thyroid cancer, which is more seamless in the later technologies that we have achieved. But this happens based on the imaging that happens on the CT scanner within the delivery machine. Newer machines even have MRI prior to delivery. So coming to the state of the art, this is our Ranipet campus new machine. This is the tomotherapy. So this, I would call, is currently the state of the art for thyroid cancer radiotherapy. What is the difference? The previous linear accelerators have a cone beam. That is, the entire region is covered in one beam which goes all around the neck. This is like a helical CT, wherein slice by slice, we are able to treat the tumor from top to the cranial to caudal end of the target. So this is a slower workflow, but it has more precision and it has better sparing of normal tissue and better tolerance of the treatment. Why is it state of the art in thyroid cancer? Because since we treat from base of skull to the anterior mediastinum, the current linear accelerator, we are pushing it to the limits of its field size. So hence we lose some conformity at the edges, but a tomotherapy can actually treat the patients from head to toe in one go. So it is actually a useful machine for thyroid cancer therapies. It is definitely expensive because of the slower workflow. We can put only lesser patients in this machine, and hence per patient the cost would go up. Also, to mention about stereotactic radiosurgery, thyroid cancers are curable and we are looking at long-term survival. So even if there are brain mets, we would actually offer a curative approach. If the surgeon can excise those lesions, we will do that as a first step. If not, we would offer stereotactic radiosurgery. Up to 4 lesions can be tackled in a single sitting stereostatic radiosurgery. There is also a new technology called hyperarc therapy, in which people have radiated 10 or 15 metastases in one go. The alternate to that is whole brain radiotherapy, as mentioned in one of the patient presented. She could have actually had an SRS or a surgery. So again, the latest in tackling the metastasis outside of brain is SABR or SBRT. For example, in spine mets, we can do palliative radiotherapy for spine mets, which we give only up to 30 gray, but that does not sterilize the entire tumor from that region. That only stops the growth of the tumor. But if you really want to ablate the tumor, we have to go high up on the dose. For that, we employ this technology called stereotactic body radiotherapy, or SABR. We do it for lung lesions, we do it for liver lesions, we do it for vertebral lesions. This can be, this is not only for thyroid cancer, for all metastatic lesions. If they are oligometastatic, we are approached and we do this. It is more important for thyroid cancer because we know the survival of the patient is longer, and hence we need to go radical on these patients. Along with, when we employ this high-focused, high-dose radiation, we also have to make sure that we target the right place because it's a small tumor. The patient's body, there is a continuous motion because of respiration and other reasons. So we actually track these, and we have technology called surface guidance and RPM. Real-time position management, which will map the respiratory movements. We take a CT scan called the 4-dimensional CT scan upfront to map the respiratory movements, and we control the radiation delivery based on the respiratory movements. Again, our accuracy is within 3 millimeter to deliver such a dose. So that's what we employ in metastatic setting. For this, we have this machine, TrueBeam. We have 2 machines, one in Ranipet and one in Vellore campus. This is a Ranipet machine, which is a TrueBeam FFF, which delivers high-dose radiation in very small time, and it helps us to deliver SBRT, SRS, and SABR. And I feel this is better than dedicated solutions like CyberKnife available elsewhere. We have this X-Knife. So what we do not have, these are what we have. In radiotherapy, what is state of the art? There is proton therapy, you would have heard about it. There is one in Chennai and another in TMH Mumbai. There is carbon ion therapy, which is being, Tata Calcutta is trying to acquire that. Though these are available, these are good for ablative radiotherapy. The utility in adjuvant radiotherapy in thyroid cancer, it's not proven, and it's quite expensive also. It's proton therapy at present is 15 times more expensive than the high-end IMRT that we provide here. MR linear accelerator, as I told you, we can actually image before treatment and deliver therapy. MR imaging added to a linear accelerator is now currently in the market, and it's coming in. Bangalore is getting one. So there we can actually do a daily MRI prior to therapy and make sure our accuracy is good. And also, if the tumor is shrinking or if the volume is changing, we can actually recalculate and immediately deliver the therapy. So it's a better adaptive workflow that we have. So to summarize, I would say EBRT is not for all thyroid cancer. As I said, it would benefit the mainly the bad tumor in prolonging their progression-free survival and excellent local control. but we should be aware of toxicity. So we should choose it for the right patient, and that is where the multidisciplinary team comes in. And if you ask me what is the state of the art, tomotherapy, I would say, is the state of the art for thyroid bed and nodal RT, and it also entails an inbuilt adaptive workflow within tomotherapy. So any changes we can actually change immediately and treat. And if it is for metastasis, which the surgeon cannot tackle, then we would have the X knife, which would come with SGRT or respiratory motion management, and we would be able to ablate and eliminate that tumor. I thank Dr. Simon, who is here, and other people who have contributed to this presentation and the treatment of these patients, and I thank the organizers for this. Any questions?
Thank you, Dr. Balu. That was a very good walk through the whole technology and what we have available. I'm sure everyone would have benefited. Please, if we can take a question, if anyone wants to. Okay, at the moment, just a quick question. Do we have, sorry, Pradeep, you have a question? Yeah.
Thank you, sir, for taking us through the entire spectrum. Sometimes we have cases where we have to consider giving both the radioactive iodine therapy as well as the RT. And we are in a situation where we cannot delay the RT because in the neck we have done a less than R0 resection, maybe R1. So in that scenario, what do you advise how to go about it?
Yeah,
how long should we wait before we go for the radioactive iodine?
Okay, so this is a very common scenario. So when we are talking about EBRT, we are talking about high-risk disease wherein there is a higher chance of local recurrence. And we are also expecting a disease which has the bulk probably is higher than what the iodine can control. So EBRT takes precedence, and EBRT, when we do EBRT, currently recommended we do a contrast scan for that. So that automatically delays the iodine therapy by 3 months. And that's the general understanding we have. Earlier, we used to skip the iodinated contrast for our EBRTs, but currently standards say we should use contrast because that helps us to identify the residual and other microscopic, other gross disease if it is there, so that we can target it better. So 3 months after EBRT is when we schedule the iodine therapy.
Thank you.
And another problem here is if there is a gross residual, if I am going to give radioactive iodine upfront, all the iodine would concentrate on the residual and you will not be able to ablate the microscopic disease. So it is always better to ablate this with radiation and then do the radioactive iodine.
Thank you. Very excellent presentation.
Thank you.
Balu. Yeah. So one question, I mean, like in breast, where the short course, this thing is coming up. If you have grossly removed the tumor by the neurosurgeon previously, and is there a chance where we can try to, decrease the duration, the standard 6 weeks? Is any
Yeah, thank you for asking that. So it takes us to the biology. So if the tumor was separate from all the structures around, we could always do it. So when you look at breast or the chest wall RT, it is always away from the body and the critical structures are not there. So what is a normal tissue that I don't want to damage is the gland itself and the chest wall. So no major consequences happen. But unlike that, in thyroid bed, we are talking about the spinal cord, we are talking about trachea, we are talking about esophagus. They don't tolerate hypofractionated radiation. So also, the fractionated radiotherapy in head and neck cancer works because when you give small fractions of radiation, the remaining tumor actually moves from a radio-resistant phase to radio-sensitive phase, and we are like kind of cyclically killing them over a period of 6 weeks. So it works better in tumor cell kill when we do fractionated radiation. So far I have not seen hypofractionated being applied in a curative adjuvant setting in thyroid cancer.
Thank you. Thanks.
Thank you very much for answering those questions.
Thank you, sir, for a very informative talk. I just have a few announcements to make. All of you who have given in the photographs or pictures, just make sure your names are written. Second thing is the rest of the poster work, which was half completed, part of it was completed yesterday. The rest of it will be done during the lunch session. And the third is the CME accreditation certificates have come. So during the lunch, you can collect your certificates. Now moving on to the next speaker, systemic therapy in thyroid cancer. May I invite Dr. Divya Bala, a medical oncologist, to speak on the same.
in systemic therapy, and look forward to Dr. Divya's talk as she takes us through all the available modalities and the experiences that we have had.
Good morning, everyone. Good morning, sir. Thank you for the opportunity and the pleasure to speak here, sir. As compared to all the gross treatment plans that have been discussed till now, I will get down to the cellular level, to the molecular pathology level, and see what we are doing, what is happening at the systemic level in thyroid cancers. So I'll go straight to the indications of systemic therapy and the choice of drug. Generally, the indications for systemic therapy are non-medullary. In non-medullary thyroid cancers, we treat radioiodine refractory diseases, which are metastatic, advanced, differentiated thyroid cancers, which are generally growing at more than 20% per year. And in anaplastic thyroid carcinoma and medullary thyroid carcinoma, which is unresectable or metastatic. So this is generally the lifespan of thyroid cancers, which we all know. Radioiodine responsive, they will go down and they'll just continue in the indolent phase and they become better. We tend to come somewhere in the radioiodine refractory area and the anaplastic area, which is where medical oncologists start coming into picture. So if we look at the way thyroid cancers, molecular pathology has evolved, I think Rekha ma'am will take us through that in much more detail. But if we look at it earlier, we only knew the RAS alterations, RET alterations, and PTC alterations. But as years went by and with the betterment in gene sequencing techniques and science, now we know there are multiple alterations and we have multiple targets and drugs which target these driver mutations. So putting it into perspective in terms of histology, if you look at it, papillary thyroid carcinoma generally carries BRAF V600E mutations as opposed to follicular carcinoma, which commonly carries RAS mutation. And poorly differentiated carcinomas and anaplastic carcinomas are characterized by more of TP53 expression. So if you, just to show you how these cell pathways are in the cell, at the cellular level, if you look at it, the receptor tyrosine kinase gets activated and there is a downstream activation of the cellular pathways which lead to transcription and proliferation and angiogenesis. So at the receptor tyrosine kinase level, if you see right on top, there is RET, PTC and NTRK. That goes down to RAS, BRAF, MEK and ERK pathway, that is the MAP kinase pathway, which is commonly taken by the papillary thyroid carcinomas, as opposed to RAS and then going down to PI3K pathway, which is commonly taken by the follicular thyroid carcinomas. Again, so what does it all mean? It just means that there is deregulated pathways which cause upregulation of MAP kinase pathway, which causes angiogenesis. There is increased angiogenesis, there is reduced iodine uptake, there is increased genomic instability and altered immune to tumor response. So which is why these TKIs and other systemic therapies work in radioiodine refractory diseases and not so much in, and it's not been tried in the radioiodine responsive diseases. So now this slide is just to show you that these are not called tyrosine kinase inhibitors anymore, they're called multi-kinase inhibitors. If you look on top, there are multiple receptor tyrosine kinases which are inhibited by the same drug. So if you look at the algorithm for metastatic differentiated thyroid carcinoma, if we go down to the, if we look at the indication, we say that the tumor is growing more than 20% per yearly. Then we go down to looking at the mutations. See, look for any, once the patient becomes radioiodine refractory, it's truly a really bad disease. So we tend to want the patients to be participating in a clinical trial. If we can find a driver mutation, we will find the target towards that driver mutation. If we can't, then it's better if they are enrolled into a clinical trial. If there is a NTRK, RET, and BRAF V600 mutation, then we have a targeted therapy for it. If there are none, then we go down to using anti-angiogenic multi-kinase inhibitors, which are lenvatinib and sorafenib, which is what usually happens in our scenario generally because our patients can't afford NTRK, BRAF V600E, and the accessibility of the drug as well. So coming to the first drug, anti-angiogenic multi-kinase inhibitor, sorafenib, which was approved in 2014 by this decision trial, where there is progression within 14 months of earlier therapy, radioiodine refractory, and no prior targeted therapy was used. So this was compared to placebo, And if we look at it, although the response rates were only around 12%, this was one of the initial drugs which led to a prolonged PFS, up to 10 months as compared to placebo, which is 5 months. However, this was not without the side effects. As you all know, there is a lot of hand-foot syndrome. There is quality of life of patient was affected by the using of sorafenib. So now the current drug, what is commonly being used is lenvatinib. Lenvatinib has a wider range of target. It targets all pan-VEGF, it targets FGFR, it targets RET, and other receptor tyrosine kinases. So this SELECT trial is a phase 3 trial which compared lenvatinib to placebo. The thing is that here they have included those who have received prior VEGF therapy. So some patients who have received sorafenib were also included in this trial. So if we look at it here, we see that lenvatinib actually has prolonged PFS to up to 18 months compared to placebo, which was only 3.6 months. There was an updated analysis which showed that the duration of response in those who were responding to lenvatinib, which was longer, so about a doubling of the response rate, progression-free survival to up to 33 months, as compared to non-responders, which is only about 8 months. So again, lenvatinib also has its own side effects, although it is not very visible like sorafenib, where there's HFS and diarrhea and all that. Lenvatinib also has diarrhea, but more of hypertension and proteinuria, which are more serious, and that these are side effects which are picked up by the clinician, not so much by the patient. So the other important thing about lenvatinib is that the response rates were up to 60% as compared to sorafenib, which had response rates of close to only 12%. So just to compare sorafenib with lenvatinib, like I said, all these things, median progression-free survival with sorafenib was about 10 months as compared to lenvatinib, which was about 18 months. And like I said, lenvatinib had a wider range of inhibition. So because of that significant side effects, a trial was done to see if we can reduce the dose from 24 mg to 18 mg, which was much more tolerable by the patients. This was a non-inferiority trial, but the non-inferiority was not reached. So reducing the dose of lenvatinib is actually inferior compared to, as opposed to continuing it at 24 mg. So this is the algorithm by ESMO guidelines, where we come towards that right corner place where patients are symptomatic with multiple lesions. That is where systemic therapy comes in. So what happens after they progress on lenvatinib or sorafenib? This is a trial which looked at cabozantinib in a phase 3 design. If we look at the baseline characteristics, we see that most of them were actually ECOG 0 or 1. Almost all of them were refractory, radioiodine refractory. Almost all of them had either sorafenib or lenvatinib or both. If you look at it, they have actually included more than 1 or 2. Almost 30% had more than 2 VEGF. Two VEGF TKIs which were used. Multiple common metastatic areas being bone, liver, a lot of visceral mets are also involved. So here, if you look at it, this is a second-line TKI that is used. And if you look at it, cabozantinib actually has caused a longer PFS. Again, here, cabozantinib, the response rates were only about 12 to 14%, but the progression-free survival was significant. So differentiated thyroid cancers, generally we prefer sorafenib or lenvatinib, followed by cabozantinib. Now coming to anaplastic thyroid carcinoma, nothing much has changed in the guidelines, except that we have, if there is BRAF V600E mutation, again going back to using dabrafenib and trametinib or vemurafenib with dabrafenib, EBRT or chemotherapy. This was the standard of care for anaplastic thyroid cancer. No matter what we do, they will progress. So chemotherapy with doxorubicin or taxane was the standard of care for a long time. If there is BRAF V600E mutation, then vemurafenib, the targeted therapy towards that. But the latest one is the use of lenvatinib with pembrolizumab in anaplastic and poorly differentiated thyroid carcinomas. This is actually a retrospective study, which was from a single center. It had only 6 patients with anaplastic thyroid cancer and 2 with poorly differentiated thyroid cancer. lenvatinib was used at 14 to 24 mg, and pembrolizumab was used at a fixed dose of 200 mg Q3 weekly. Now, if you look at the objective response rates, in the first 3 months, there's about 75% who had partial response. If you look at anaplastic thyroid cancer, these guys had more of response, and that got converted into complete response towards the end of 16 months. So if you look at best overall response, to see an anaplastic thyroid cancer having complete responses was almost like a miracle. Although this was a retrospective analysis, it was only 6 patients. Further analysis showed that those who had durable response had a TPS PD-L1 tumor proportion score of more than 50%. Again, because lenvatinib is involved, there are about 50% patients who had grade 3-4 toxicity, which required dose reduction. So this is the curves which are showing the prolonged PFS with, in ATC, the PFS is prolonged with lenvatinib and pembrolizumab, and that's more in anaplastic thyroid carcinoma. So coming to medullary thyroid carcinoma, just to cover medullary thyroid carcinoma as well, again, we come somewhere close to here, where this right corner, where this patient is progressive, symptomatic, multiple lesions, when everything else can't be done, then systemic therapy with cabozantinib and vandetanib. In medullary thyroid carcinoma, although it's a neuroendocrine tumor, we have a lot of, the classic teaching is that the red proto-oncogene is mutated, but there are also a lot of other receptor tyrosine kinases which are constitutively activated. So we actually have a larger range of drugs which we can use in medullary thyroid carcinoma, except immunotherapy, of course, because PD-L1 is not, although PD-L1 is expressed, it's not, the inhibition of PD-L1 has not been shown to be effective in medullary thyroid carcinoma. So the studies are ongoing for use of CTLA4, the co-receptor expression, of the immuno-co-stimulatory molecule CTLA4, which is ipilimumab. So these are the drugs. This is just a list of drugs which we use in medullary thyroid carcinoma, commonest being vandetanib and cabozantinib. What are we looking at in MTC? Mostly we want as much response rate as possible, so we can again bring patient back to you to do the resection and do a local therapy. So vandetanib and cabozantinib, if you look at it, there's overall response rates of 45% and up to 30%. Now the latest addition is RET directed. In those who are RET mutated MTCs, selpercatinib and pralsetinib are the ones which are being used. Even though there is a previous TKI use, you can see up to 60 to 70% response rates in both these drugs. This has not come to clinical use in our part of the world yet, but we look forward to having these things with those who have RET mutation to have these drugs. So in summary, differentiated thyroid cancers, commonly papillary and follicular. So if you were to use a TKI, I should call it an anti-angiogenic multikinase inhibitor. Lenvatinib preferred more than sorafenib. In second line, we can use cabozantinib. MEK inhibitors. Now, this is a newer concept where, with the use of MEK inhibitors like selumetinib, there is a redifferentiation of the cells that is happening, which has been noted. So they can actually go back to using a radioactive iodine therapy again. So that is a concept that is being actually evaluated now. In anaplastic thyroid cancers, chemotherapy will always remain the mainstay of therapy until we have proper trials which are showing lenvatinib and pembrolizumab as a thing that we can use. Again, how they will come into, whether we can actually produce a robust evidence is difficult because of the lesser incidence of the disease itself and the shorter time that the patients give us to do any trial. Medullary thyroid cancer, targeted therapy with vandetanib and cabozantinib, and like I said, selpercatinib and pralsetinib are the newer addition to this armamentarium of systemic therapy. Thank you.
Thank you so much for that overview. Yeah, I understand that the selpercatinib trials are going on. We just enrolled one patient. In India, we have three centers.
Clinical trial.
Clinical trial, yeah. The question of MEK inhibitors, are they in use? Selumetinib?
Selumetinib is in use, sir, but I'm not sure if we are using here.
We haven't, okay.
Yeah.
And do we have trials for the anaplastic with Lenva-Pembro combination?
Right now, there is a trial going on, not here, sir, but there are trials going on elsewhere in the world. What we have a trial right now is for BRAF V600E mutation in differentiated thyroid cancers. That we are actually part of that study.
Okay. And what does that use?
We are using Vemurafenib,
Vemurafenib.
dabrafenib.
Okay, any question? Yes, Ranjit?
Do you decide these TKIs based on this mutation analysis and then decide, or just offhand?
No, not offhand. We try to do mutation analysis as much as is possible. Here we check BRAF V600E mutation. If it is there, we try to enroll the patient into anywhere there's a clinical trial that is going on. Otherwise, yes, like a blanket use anti-angiogenic multi-kinase inhibitor, lenvatinib and sorafenib for all thyroid cancers.
Okay. Is this cabozantinib available in India?
Yes, yes, pretty much. And
How
it's
much does
quite
it cost?
affordable as well. Sorry?
How much does it cost?
Per month, about 9,000. 40
that's
mg
all.
is about 9,000
Okay.
rupees. Yeah, pretty. Actually, all of drugs are accessible.
How is
and
your experience about using it? How is the
Cabozantinib?
response? Yeah.
So with cabozantinib, we see much of hand-foot syndrome, a lot of diarrhea, and a lot of fatigue more than anything else for the patient, and less of response rates. With lenvatinib, you can actually see that the tumor is shrinking. If there is a large tumor which is undesectable, you can see that it's slightly shrinking. With cabozantinib, we don't see so much of change in the tumor. There's mostly stable disease, but it just remains stable for a long time.
So it just converts to overall survival rather than the
Cabozantinib.
PFS. Yeah.
So I think overall survival is not the hazard ratio is crossing unity for overall survival. We do get a prolonged progression-free survival, and we tend to reserve cabozantinib for a second-line therapy after having used another anti-angiogenic MKI, multi-kinase inhibitor.
Okay, thank you, doctor.
One more question. Yes,
Yeah,
Siddha.
nice presentation, madam. So my question in lines with, when should we consider doing NGS, particularly in thyroid cancer? That's one. And is the report, it takes at least 2 weeks is what I understand. And do we have most of the drugs that come in that panel? If we take poorly differentiated thyroid carcinoma, is it available? And if you could also explain on the cost of the medicines, at least the ones commonly used, will be helpful. Thank you.
Sure. So when the moment the cancer becomes, if it's non-medullary thyroid cancer, the moment it becomes radioiodine refractory, I think it's best to send off for NGS. Whenever the report comes, we have that ready. First, like I showed you in the previous algorithm, first thing to check is for known mutations, NTRK, RET, and BRAF V600E, because that trials are going on, the drugs are available. Indian trials, in some centers they are going on. So first to check for those three, which is, we do BRAF V600E here. The rest of them, we can send for NGS. Once if BRAF V600E is not there, then you can send for all the other mutations. Your next question was the cost of drugs. So sorafenib is pretty cheap, 3,000 to 4,000 a month. We start with half the dose of 200 mg BD and escalate to 400 mg BD as per patient's tolerance. Most of our patients will get up to 600 mg a day. Most of them don't reach 800 mg a day because of the hand-foot syndrome. Lenvatinib, we always start at 10 or 14 mg. We can actually in our population we have seen we never reach up to 24 mg, which is why that trial also 18 mg versus 24 mg. Although it is shown to be inferior, we actually cannot ever. I have not seen any patient who reached to 24 mg of lenvatinib on therapy. Although we do see responses with even that lower dose. Probably our biology is different. Our racial biology is different. Yeah, that's the thing. Cabozantinib 40 mg costs about 9,000. Lenvatinib is also pretty affordable, less than 10,000 in a month.
How should we know whether which trial is going? Is there a registry in India where the clinical trials are, we have to approach the medical oncologist only?
There's clinicaltrials.gov. I think we also check on that only. Yeah, so the recruiting centers, you will know from that.
It'll list all the recruiting. So you see where the Indian center. Thank you so much. That was very useful for us. A big hand to Divya. Thank you.
Thank you, Dr. Divya, for that talk. Now, moving to the next talk, may I invite Dr. Kripa for her talk on hyperparathyroidism, changing trends and future perspectives.
Okay, so we'll take a slight detour from the toxic oncology environment, go to parathyroid, and I'm glad to introduce Kripa, who's the associate professor with endocrinology, a very close partner in management. Thank you.
Thank you, Paul sir, and good afternoon to all. Today I'd like to cover a few pertinent aspects of primary hyperparathyroidism, and this is the outline of my talk. So when you look at hypercalcemia per se, it is prevalent in about 2% of the population, and of this, majority is accounted for by PHPT and malignancy. Nevertheless, it is worthwhile to run through the differentials of hypercalcemia, which is abbreviated as vitamins trap, all the way from vitamin D intoxication down to parathyroid disease. Now, when you talk about the epidemiology of PHPT, almost more than 2 decades back, the concept of asymptomatic PHPT was virtually unheard of in India. But this scenario is changing. We have a greater prevalence of asymptomatic PHPT as compared to before. And one of the reasons attributed to this is better calcium and vitamin D nutrition. With regards to clinical manifestations, we are all aware of the Fuller-Albright's pentad, and studies from India, this one from Kashmir, this one our own series, have shown that skeletal and renal manifestations are among the most common. Now, of late, we have also encountered a few of the more obscure manifestations that I'd like to touch upon. The first is of a 48-year-old lady who actually presented to hematology for the evaluation of anemia that was refractory to multiple transfusions and iron supplements. And rightly so, she underwent a bone marrow biopsy, which showed a marrow fibrosis and a state of high turnover. It was then that she was detected to have a PTH-dependent hypercalcemia, a right inferior adenoma for which she was operated. She had recovery of her symptoms and a gradual improvement in her cell lines. So PHPT presenting as myelofibrosis. The second is of a 61-year-old lady who was on treatment for a metastatic CA breast. She came with worsening bony pains and hypercalcemia. So we thought it might be a recurrence of the bony metastasis. However, her bone scan was normal. She also was found to have a primary hyperparathyroidism, a right superior lesion for which she underwent surgery, and there was improvement in her symptoms. So in the context of a metastatic malignancy also, it can be a rare presentation. This lady, a 38-year-old, was on over-the-counter NSAIDs for bony pains. The reason she came to us was swelling in both her lower limbs, and on evaluation she was found to have a DVT. So following evaluation, she was found to have a primary hyperparathyroidism, and despite having severe disease with almost all her bones being fractured, she came with the first presentation as a DVT. Of course, she had a prolonged hospital stay and rehabilitation, and at the end of 1 year, she's just about ambulant. So hypercalcemia can cause thrombosis, and this is mediated by an activation of coagulation factors and platelets, vascular calcification, vasoconstriction, and dehydration. When we talk about the evaluation of PHPT, this is the entire gamut of investigations. But firstly, I'm interested in confirming the diagnosis with an albumin-corrected calcium and a PTH. I would want to know how bad the bone is, whether there is vitamin D deficiency, what the renal functions are like, and whether there is hypercalciuria or phosphate wasting. I would also screen for an end organ damage, whether there's osteoporosis, fractures, or nephrolithiasis. I will just touch upon what the TMP-GFR, or the tubular maximum for phosphate corrected for GFR, is. Usually, PTH causes a phosphate leak, and this is confirmed using the Bivouet's nomogram. For this, I would require 2 parameters, the serum phosphate and the fractional excretion of phosphate. And for example, if the serum phosphate is 2 and the fractional excretion of phosphate is 0.5, I would draw a straight line connecting 2 over here, 0.5, and read the TMP-GFR as 1. The normal range is 2.5 to 4.5, and anything less than this indicates a phosphaturia. Now, based on my preliminary evaluation, I will be able to narrow down on the differentials of the kind of parathyroid disease, Other rare considerations would be the use of drugs like thiazides and lithium that can also cause a mild hypercalcemia. These will require to be cautiously withdrawn for at least 3 months before a re-evaluation. Of course, molecular genetics is also in vogue. PHPT can occur as part of several syndromes like MEN1, 2, 4, the HPT-JT syndrome, or a familial isolated parathyroid adenoma. When would I suspect a genetic cause? If the patient is young, if he has manifestations pertaining to the other endocrine glands, if he has a strong family history, yes, then that warrants genetic testing with all these candidate genes that are listed here. If any of them is positive, then the patient requires to be followed up periodically for the development of other manifestations. His family members would need to be screened as well. This another case of a 28-year-old gentleman who presented with an ethanol-related pancreatitis. During this evaluation, he was found to have a PTH-dependent hypercalcemia. However, his BMD was completely normal. On investigations, yes, he had a PTH-dependent hypercalcemia, but what was curious was the very low urine calcium that he had. So we wondered whether it could be an FHH. We asked him to bring his father and also subjected him to the same investigations, and he had a similar picture as well. So FHH needs to be excluded in select circumstances, and this is done using a 24-hour urine estimation. When it comes to management, there are two aspects, the pre-op management and definitive management. In the pre-op setting, I'm concerned about hypercalcemia. The severity of hypercalcemia can be graded as mild, which is 10 to 12 milligrams of calcium per deciliter, or severe when the patient can present with a hypercalcemic crisis, more than 14 to 16 milligram per deciliter. And how would I address the hypercalcemia? I would start with conventional measures of hydration with diuresis. Parenteral bisphosphonates can be administered. Calcitonin can be given if it does not settle. In life-threatening cases, the patient will require to be dialyzed, and of course, calcium mimetics can be added. Now, sometimes, rarely, patients with primary hyperparathyroidism can have a renal dysfunction. And when the GFR is less than 60, then that is a condition that precludes the use of parenteral bisphosphonates. Denosumab is a reasonably new agent, which is a monoclonal antibody to the rank ligand, which can be safely given in such settings as a bridge to surgery. The dose is 60 milligrams subcutaneous. Now, there is also some talk about vitamin D deficiency and PHPT, and a cursory search has yielded almost 600 results. Now, previously, this was an area of contention in the sense that can vitamin D be supplemented in the face of hypercalcemia, but over the last 2 decades, there is enough evidence that has accumulated to say that vitamin D deficiency is associated with a more severe bone disease. The calcium is lower to a normal level, and that can cause some diagnostic uncertainty, and there is a more chance of hungry bone syndrome developing post-op. So based on a meta-analysis of available studies, vitamin D supplementation in PHPT has shown to reduce PTH without worsening the hypercalcemia and hypercalciuria. Surgery, of course, I'm talking to a crowd of surgeons. Any symptomatic patient warrants surgery. When the patient is asymptomatic, then we go by the criteria of age less than 50, calcium 1 milligram above the upper limit of normal, and the presence of end organ damage. If the patient does not meet these criteria, he is followed up regularly, and any time he meets the criteria, he warrants surgery, which can be a focused parathyroidectomy when pre-op localization unequivocally shows a single gland, or when it is not localized in the context of syndromes or multiglandular involvement, a cervical exploration. Of course, again, I don't need to talk to surgeons about the utility of an IOPTH as well. This lady, 47-year-old, presented with bony pains and weight loss. On examination, she was found to have a hard mass on the left side of the thyroid. She had a primary hyperparathyroidism due to a left inferior lesion. In the surgery notes, I came across that there were tumor deposits in the muscle as well, and the histopath came back as a parathyroid carcinoma. So this is rare and accounts for less than 1% of patients. It can be sporadic or as part of a genetic syndrome. About 40 to 70% of patients can have a palpable mass, and the treatment is a complete excision followed by chemo and RT. There will be some patients who might refuse surgery or may have multiple comorbidities that would make them poor surgical candidates. What do? We should avoid factors that would worsen the hypercalcemia, like thiazides and lithium, encourage them to be adequately hydrated, not to limit their physical activity because that can worsen bone resorption, and encourage optimal vitamin D nutrition. So previously, cinacalcet was extensively used for secondary hyperparathyroidism in CKD, but now it is approved as medical management for PHPT, and this was a recent meta-analysis that showed that it does have favorable effects on calcium and PTH, though evidence on fracture risk and renal calculi are lacking, and there is not much change in the BMD. So a combination of cinacalcet to normalize the calcium and bisphosphonates for the sake of BMD is an appealing option where surgery is precluded. How would I follow up the patient? I would do a calcium, phosphate, and a PTH. I might anticipate hypocalcemia, which can be because of a hypoparathyroidism or a hungry bone syndrome. And how do I distinguish between the two? Both will present as hypocalcemia, but while hypoparathyroidism is associated with a high phosphate and a high urine calcium while on calcium replacement, hungry bone syndrome is associated with a low phosphate and magnesium and low urine calcium with calcium replacement. Once the patient is cured, he needs to be followed up at least annually with calcium measurements. If hypercalcemia recurs with a raised PTH, repeat surgery is warranted. If, however, he remains normocalcemic, a routine PTH assessment is not recommended. This 38-year-old gentleman was operated for a tertiary hyperparathyroidism due to CKD. He was being monitored with serum calcium. However, on the third postoperative day, he developed severe symptomatic hypocalcemia, and his investigations were suggestive of a hungry bone syndrome. So he developed seizures actually, and when he had seizures, he developed new fractures of both his hips and the right shoulder as well. So hungry bone syndrome is rare, though not uncommon. Its treatment requires several days of parenteral calcium infusion, high doses of active vitamin D, oral calcium supplements, and might take almost 6 to 12 months to recover. So its duration actually mirrors the duration required to remineralize the skeleton. Some of the risk factors cited are very severe skeletal disease, very high levels of PTH, calcium, and alphos pre-op, along with a concomitant vitamin D deficiency. What are the outcomes? So this 42-year-old lady underwent a curative parathyroidectomy. Preoperatively, she had a low bone mass. Her Z-score was minus 2.5 at the lumbar spine. In 6 months, this normalized, and this improvement was sustained at the end of 1 year. And these results are indeed gratifying. I would also like to touch upon our series. This was done by one of my colleagues. This was a prospective study on 51 patients with PHPT. They were followed up for 2 years with respect to their bone health. And at all 3 sites, that is the femoral neck, the lumbar spine, and the distal forearm, there was significant improvement in BMD. But what we also looked at was that the entire cohort was divided into two groups based on the PTH of high PTH more than 250 and a low PTH group less than 250. And we compared them at baseline, the end of year 1 and the end of year 2. And we found that there was no difference between these groups in BMD at the femoral neck or lumbar spine, but the BMD at the forearm remained significantly lower in those subjects who had a high baseline PTH, indicating that PTH causes severe cortical bone loss. In recent times, there is this terminology that has come up, normohormonal primary hyperparathyroidism, wherein the calcium is normal, the PTH is not high, it remains in the normal range and is not suppressed. Not much is known, but available literature has shown that there is a greater chance of finding multiglandular disease, greater chance of a negative cestum maybe, lower weights of the adenoma during surgery, and a slower rate of decline in PTH post-op. Whether this is an early variant or whether this is a distinct variant, perhaps only time will tell. So to conclude, right from the discovery of the parathyroid glands in the Indian rhino, our understanding has evolved and come a long way. With regards to primary hyperparathyroidism, the epidemiology has undergone a welcome change with less severe manifestations. More obscure manifestations are we see. Molecular genetics is done when indicated. When there is hypercalcemia in the setting of a CKD, denosumab is a safe option. Once again, hungry bone syndrome is not uncommon. A combination of cinacalcet and bisphosphonates may be used when surgery is not an option. And normohormonal PHPT is a recently described entity. I'd like to thank my colleagues in the Department of Endocrinology and Endocrine Surgery, because whatever I have presented is only teamwork. Thank you once again.
Thank you very much. Very interesting cases and a good overview. Any question? One question I have is about, asymptomatic hyperparathyroidism. Our experience has been, even with the availability of so many labs and private centers, we've not really seen a big increase in asymptomatic PHP.
Not so much in our center, but the proportion has increased considerably. There was a recent series from PGI which showed that in their center it was around 3% a decade back, and now it is almost 15%. So there has been a relative increase. But symptomatic disease is still more common.
Yes, that's true. Any?
Yeah,
Siddharth?
Regarding that asymptomatic, sir, I mean, now I'm seeing a lot of asymptomatic because of health checkups.
Okay.
So a lot of population, health-seeking population, it's become very common. So we really see only the calcium, and we follow the guidelines. Unless it is more than one, we don't operate.
Okay.
That's the second thing. I have a question. Post-parathyroidectomy, I tell my patients to just do the calcium and keep reporting. Every patient, almost everyone does a PTH also on his own. And then
the PTH is usually found to be high, and that was what we found in our series
what is
well.
the percentage of patients who can have high PTH, but of course the calcium and all is normal, and why does this high PTH happen, and how long will it take to stabilize, and what happens in the long run?
So the mechanism of the PTH coming back high is not exactly known. This was seen in almost all our patients, about more than 60% of our patients in our center. It does come up to stay more than the normal reference range. So we don't routinely ask for a PTH because it only causes concern for the patients. So as long as the calcium is normal, then we don't routinely assess it. So because we don't do it repeatedly, we don't know whether it comes back to normal or how long it takes to come back to normal.
Is it because that you have that bone disease and it is healing? So that process itself needs PTH for bone deposition. Is that maybe a cause for this?
Probably. I'm not able to answer you completely, but yeah, usually the physiology of PTH and calcium is dependent on the ionized calcium, and as long as the ambient calcium is normal, then the PTH is
Yeah,
usually
they
not high.
maybe they require more calciums and there is a more deposition into the bone. So
Yeah, that happens during the phase of hungry bone syndrome. During
but there
the,
is a subclinical form of hungry bone. Maybe, we don't know.
Yeah.
But have you correlated that with the BMD? That's what I'm asking.
whether PTH and the BMD,
Yeah.
and we haven't looked at that correlation. BMD
And bone
shows a
markers.
significant improvement,
Bone
and the
markers.
bone markers also significantly come down on follow-up.
Okay,
Thank you. We have a last question here.
At our center, for the patient which presented with hypercalcemic crisis, the endocrinologist usually gives zoledronate. So after that also, and after performing surgery, we've seen that there is the time duration of rise of PTH is more. It takes more than longer time to get normal. Have you experienced something like that with zoledronate?
As in the PTH coming down to normal.
It usually takes more than a year for PTH to come down if those patients have received zoledronate in preoperative time.
Have you studied that, or is just a
I think there are
anecdotal observation?
3 or 4 cases. There is no formal study. We still.
They say that the occurrence of hungry bone syndrome is mitigated if zoledronic acid is given. With regards to PTH, I have not come across.
Okay, thank you. Thank you very much. That
Thank
was
you,
very
sir.
interesting.
Thank
Thank
you,
you, Kripa. We'll now move on. Yes?
Yeah, thank you, Kripa, for that talk. Now, for the last talk, may I invite Dr. Rekha Pai to speak on the topic, Impact of Molecular Markers in the Management of Thyroid Nodules, a Differentiated Thyroid Cancer, Medullary and Anaplastic Cancer.
Yeah, thank you. Dr. Rekha runs our molecular path lab, and we work closely from the Department of Endocrine and a lot of departments she works with. And she has a vast experience. So I've given her a big topic, and I'm sure she'll do a good job. This is about both impact on nodule management as well as cancer. So over to you, Rekha.
Thank you, Dr. Paul, and thank you for this invite that you've given me. I hope I can do justice, because today we are in a day and age with so many molecular markers that it's quite hard to keep a track of all of them. I understand this is also the last talk just before lunch. I don't know much about hungry bone syndrome, but I can tell you there's a hungry stomach syndrome operating here. I'll try to keep it as brief as possible. And before I begin, I'd like to also place on record that I've also had the opportunity to work with Dr. Arvindan, who's here, and also his wife, Dr. Sheila Nair, who was the head of the Department of Pathology, who's been a major figure in encouraging us to set up these tests. I don't need to really speak about thyroid cancers. You've heard enough about it, but I'll straight go down to what happens when you send an FNA sample and the cytological analysis, and from there, how we can take it forward. As you know, once you send a FNA sample to the laboratory, when cytological analysis is done, often enough, about 70 to 80% of the time, cytology analysis would clearly declare it as benign or malignant. Now, there is a good 20 to 30% which could fall into what is called the indeterminate category. I'm sure you all are all very familiar with this category. If the Bethesda system of classification is to be followed, the Bethesda category 3 and 4 actually are the ones which we should be worrying about, where there is a chance that it could turn out malignant, and therefore you would be very, very cautious with this sort of a report. Now, this is an area which has become an area of intense work when it comes to molecular markers being used. And over time, there has been this big question which has been asked. Is it possible to use a molecular marker to overcome the unknown in this category? Would we be able to reclassify this 20 to 30% of the nodules in this particular category, which is referred to as indeterminate, and can we actually reclassify them? This is where molecular markers come into the picture. And in the next few minutes, I'll take you through some of the latest. Please sit through, because much of it may be just going over your heads, but I'll try and simplify it as much as possible. And I'd like to emphasize, knowing and reclassifying this category is very, very important, because you could overcome this dilemma of whether to operate or not to operate, and the patient may benefit if you're able to clearly declare that it is not malignant. Okay, so where did all this begin? It all started in the early 90s itself. There was this description that certain mutations could be associated with follicular thyroid carcinomas, and gradually, if you look at this diagrammatic representation here, gradually over time, you will find that by 2015, almost 90% of the thyroid cancers, I'll repeat this again, 90% of thyroid cancers could be carrying one molecular alteration or the other. So now, if we put and synthesize all this together, is it possible that you have one genomic testing system, a small panel, which could be tested, and therefore you could actually declare whether a given FNA sample is actually malignant or benign? Is that a possibility? That is something with time has been answered. Okay, so if you look at this picture here, I'm sorry if I can take you back. Yeah, if you look at this picture here from the 90s, things have evolved. Okay, I think this was the same picture which Dr. Divya also had. And if you look at this over time, you will find from 1990 to date, there have been a whole load of molecular markers. It's not just the RAS or the PTC, it's also the RAS PTC along with the BRAF, and I think I've highlighted it in the 2014 image. If I may just take you to, yeah. So as a result of all these molecular markers, we'll look at it a little more in detail. It has now become possible to not just take cytology upfront to management, but the concept of using molecular markers has come to stay. So what exactly do we need to understand among these molecular markers, and how do we move forward? Now, if I have to actually get you to understand this concept better, we need to pay attention to what is on the screen. I understand some of this may sound a bit boring, but if you don't get these concepts right, you're not going to understand my subsequent slides. If a test has to be useful at the stage of screening, it has to have a good positive predictive value and a good negative predictive value. So what exactly is a good positive predictive value? What are we looking at here? If a test has been performed and you get a positive test, did the individual really have disease? If so, your positive predictive value is going to be good, which means you're able to rule in and say, yes, there is malignancy. Okay, so these are considered, any test with a good positive predictive value could be considered as a good rule-in test. Okay. Now, what is a good negative predictive value? When a test is giving you a negative result, truly the individual does not have disease, it will give you a good negative predictive value. In other words, you're ruling out, you're saying there is no malignancy. An ideal testing system would be if there is a good positive predictive value and a good negative predictive value. Okay, such tests, it's utopia. You're not going to have tests where you will have very good predictive values on either side. And also please note in the diagram representation here, you will note that it is largely dependent upon the prevalence of the cancer as well. Now, at 40% prevalence, your negative predictive value, okay, will be only about 85%, whereas your positive predictive value will go up. But as the cancer, the prevalence of cancer goes on decreasing, your negative predictive value will increase, but your positive predictive value will decrease. So now it's a combination of not just both, it's a combination, it is largely dependent upon the prevalence of cancer. Okay, keeping this in mind, let's see how people have used these concepts and gone ahead, and I'll start with all the commercial testing systems that are available, so that you are familiar with what is available universally and whether we can use them in our system or not, in our current setting or not. So to begin with, I had described so many different molecular markers. There was not enough time to go through each one of this. The first of the testing systems actually incorporated 7 different markers. I'll quickly take you through these markers. BRAF that we have here, BRAF, we mainly look at a point mutation, a change at one given nucleotide, okay, which is referred to as V600E, that is at 600th codon. The valine has changed to glutamic acid. So this is often seen mainly in papillary thyroid carcinoma. About 40 to 50% of them can carry BRAF V600E. Now then comes the RASes, the NRAS, the KRAS, the HRAS. Now these are usually present in follicular thyroid carcinomas, but you could have them in anaplastic thyroid carcinomas and poorly differentiated carcinomas as well. Unfortunately, complicating the matter is that in follicular adenomas as well, you could pick up some RAS variations. That actually brings down the positive predictive value of your testing system. All right. Similarly, there are RET PTC variations and PAX8, and that's somehow missing in my slide, or it's towards the end. There is PAX8, PPR gamma, which could also be seen as fusions, okay? These result in proteins which are fusion proteins, which are chimeric in nature and therefore could aid in tumorigenesis. Now, the first of the panels actually put these 7 markers together, and as a result of this, they found that the positive predictive value, now look at all the markers that they've used. They've used those only found in the case of malignancy. As a result, the positive predictive value of their test was high, but the negative predictive value of their test was low. Where would that put that test? Is it a rule-in or a rule-out test? It's a good rule-in test. That's where the world began. Okay, this was way back. This is not any time now. This was way back in 2011. Okay, the world moved on and we had to find a good rule-out test as well. Okay, so in 2012, the first time what is referred to as a gene expression classifier. Please remember, this is all in a period before the advent, I won't say advent, before NGS became mainstay. Today we will talk a little more about NGS and how that's become important. So this was a testing system which came along immediate next year after the 7-gene panel, where a company called Veracyte developed it. They looked at the gene expression of 142 different genes. Now this is not very simple to establish. This is proprietary. We can't actually establish it in our labs, but they managed to classify most of these indeterminate categories either directly as benign or suspicious. Now, when they looked at it further, it lent a very good negative predictive value, but it did not have a good positive predictive value. So here you had a new testing system, which was a good rule-out test. Okay, you could rule out malignancy, but you can't confirm that the ones in the suspicious category are surely malignant or not. And when that was looked at further, many of them turned out benign. So, you know, the utility of this testing system was still very doubtful. Then a couple of years later, in the year 2014, the ThyroSeq 2 version, the first one, the 7-gene that I spoke about, is referred to as version 1. The ThyroSeq version 2, which was in the year 2014, came along. Now, if we look at the ThyroSeq version, this actually was a major change from all the previous systems that was available, because this was a period when NGS actually came into play and started getting established in most laboratories. Now, for the uninitiated, next generation sequencing is a system where you can look at multiple genes all at one time. You can have it as a targeted panel. When I say targeted panel, you could choose the genes of interest, okay? So in this particular case, what they chose to do is look at certain spots, which we refer to as hotspots. What exactly are hotspots? Hotspots are where we have known mutations, where you don't need to look at the entire gene, but you need to look at select mutations. For example, a good example would be BRAF V600E. You're looking at not at the entire BRAF, but you're looking only at V600E. So these people had several point mutations put into it. They looked at insertions, deletions in genes, about 14 different genes. They had about 42 fusion proteins that were being looked at. And they also looked at the expression analysis of several of them. What did this testing system really result in? This testing system really resulted in what is called as a good rule-in and a good rule-out test. Why? Because the negative predictive value, okay, to rule out and say there's no malignancy was pretty high at 97%. And for the first time, we had a testing system with a reasonably good positive predictive value as well. And then once the result is available, looking at the type of mutation in this, whether it's a RAS mutation, whether it's a RAF mutation, whether it's a fusion, one could also declare what type of thyroid cancer, what histological type of thyroid cancer that the patient could have. So at this point in time, several other testing systems came in as well. Okay, these were not entirely based on mRNA expression or looking at looking at point mutations or gene expression. This was slightly different. Here, a combination of 7 genes along with what is referred to as miRNA. Would you all have an idea of what is miRNA? They're small, non-coding RNA sequences which have a bearing on how a given gene would be expressed. Okay. So there came in a few other testing systems like the ThyGeneX, which is used always in combination with the ThyMerge or the ThyMiRNA panel. And as a result, they did point out that their testing system could give up to 94% negative predictive value and a fairly good positive predictive value as well. But the problem with some of the newer testing systems, along with that came in the Rosetta. The problem with all these newer testing systems is they are not exactly well validated. There are very small cohorts where they have been tried. So we really don't know the value of these. But if they are compared with the standard ThyroSeq commercial testing system available, the ones which really stand out is the ThyroSeq with 97% positive predictive value, 97% negative predictive value, 77% positive predictive value. And in comparison are some of these miRNA-based testing systems which are sort of comparable. But at this point in time, okay, if we look at the data, people were still not happy. You wanted better positive predictive value. So the latest testing system available is called as the ThyroSeq 3, which is again an improvement over the previous system that is available. I won't take you through too much through this, but this is the latest system as of 2018, and this really needs extensive evaluation in multiple centers. But the data available today indicates very good positive predictive, negative predictive value and a fairly good positive predictive value. But if we have to take all this together, what we have to remember is that classifications change. In the year 2016, there was yet another new category, which is the NIFT-P. I'm sure you all have discussed this previously. The NIFT-P includes what we consider so-called benign, though they may be precursor lesions. The NIFT-P category is supposed to be classified as in the indeterminate as benign, but often enough the data shows that they get classified in the indeterminate category, and therefore this could be a problem for all the tests that I have described so far. So it's like I don't know if it's going to be a wrecking ball. This hasn't been evaluated in all the testing systems that I have described so far. So we don't know if the data is all set to change. But how useful is this data? Has this been evaluated in utilizing it in context of patient population and in utilizing it in context of your day-to-day practice? So there's a little bit of guideline available here. The American Thyroid Association did come up with a statement saying that you need to consider these testing systems. However, in your own setup, in your own hospital, you need to consider what is the prevalence of the cancer, and therefore you will be able to decide which of these testing systems will be useful. So there are many other papers like that which go on to point out that these testing systems are useful and that you need to incorporate them. The NCCN guideline of 2018 also goes on to say that if you have the AUS, FLUS category, or you have the Bethesda category 4, you could consider these testing systems. So also the latest NCCN guideline, which is 2022, also goes on to point out that you could use these diagnostic systems. Now, the question you would have for me at this point in time is, are these commercial testing systems easily available? Are they cost effective? The answer to both would be no. Okay, these are mostly proprietary, so you would have to send your sample to whichever center which is offering these testing systems. Second, they run in lakhs, okay, the bill could run in lakhs, so you're not sure whether it would be useful for the patient, and the affordability could also be a big question. So These are all the commercial testing systems. For the lack of time, I have not included those which are non-commercial. When I say non-commercial, individual laboratories like us could be making their own testing system. That is where we are headed right now. Dr. Riju at our center is actually looking at developing his own testing system with several fusions and mutations going into it under the guidance of Dr. Deepak Abraham. And we do hope in the next 2 years we will have some sort of an answer where we have a non-commercial testing system which is run in our laboratory, which could be far more cost effective. Okay? So again, many of these testing systems are available only in the western parts of the world, where it is being utilized, mostly in America, even parts of Europe, wherever, whichever publications are available will tell you it is not cost effective and hardly used in Europe as well. So that is your answer for whether these testing systems can be used. Now, where do we stand in India? Years ago, we had looked at BRAF mutational analysis. Dr. Paul was a part of the study, and so was Dr. Deepak. And we looked at 277 FNA samples directly, prospectively enrolled them, and looked at BRAF among these samples to see if it was a useful marker. Though BRAF was seen in 27% of the FNA characterized, it wasn't particularly useful in Bethesda category 3 or 4. And I don't think BRAF alone would be useful. And that data has been reflected by a few other studies in India. Some of them who have evaluated on the histopathological sample available, that is the tissue, some have looked at it in the FNA. But apart from looking at just BRAF or just TERT in India, there's hardly anybody who has actually developed a panel. So that is our status in India, where we really don't have a panel which could be for, let's say, pan-India use. And time now for most molecular labs and along with the surgeons to sit together and design a panel which is for pan-India purpose. We do have at our center what is called as an ultra-sensitive testing system, which is now available. So for those of our patients who could be BRAF or TERT positive, we do have the possibility of using what is called as a droplet digital PCR system. And with that, we may be able to do a much better job than what was initially done when we did the prospective analysis, where we used a Sanger sequencing, which may not be very, very sensitive. To sum up what I have just said about all these panels that are available, in the Indian context particularly, please remember the cost is a major factor, and also that these tests are not readily available makes them not so useful for us in the Indian context. Very quickly, I think I'm run out of time, but I just have 2 slides. One is that please remember that all the molecular markers that I might have put together and spoken to you about the panel can individually be used even in context of prognostication. Okay, you need to risk stratify, you need to understand how this tumor is likely to progress. It's possible to use them even in that context. It need not be only in context of using them in terms of thyroid nodule or FNA samples that are sent to the laboratory. Given here are several examples. BRAF we know is useful in context of PTC. TERT mutational analysis has become important in context of FTC initially. Today, TERT plus BRAF is used for prognostication. However, they haven't become mainstay. When I say that, it's not something which is a part of the standard of care. They are not sent regularly to the laboratory for estimation. Sporadically here and there, we do get some requests, but we are ready for it because we have an ultra-sensitive mechanism, that is the droplet digital PCR system, where we are able to look at BRAF and TERT in these individuals and tell you if a combination of such is seen in these patients. Now, along the way, other mutations have also become important. Dr. Divya went on to show you that NGS is sort of the way forward. We have a 72 gene panel here. Now, those patients where you would like to know if a particular drug can be targeted, we do have a 72 gene panel. So let me go back to my previous slide. Here is a list of all those which are currently used for prognostication, but again, I must tell you, whether it's P53 or whether it's P10, AKT, PIK3CA, CTNN-B1, whichever, or the RAS mutations or the RAF mutations that we're talking about, none of these have become what do I say, a standard of care where you would send these tests as a request to the laboratory. But we don't know how in future it might pan out, so we do have a panel available. And I think most of you should go back to your laboratory and talk to them about having similar next generation sequencing panels so that it could be utilized as and when necessary, either for prognostication or from the therapeutic aspect. Okay, so this is where I would end, and I've overshot by a few minutes, but the topic is sort of extensive. I do hope before lunch, but still you all have benefited from this. And thanks are due to the Department of Endocrine Surgery and Endocrinology for supporting us along with the Department of Pathology. Thank you.
Thank you very much. That was very useful. Quick 2 questions, if anybody would like to ask any doubts. I think there's one, stall is actually put out a panel which they're offering for, they said about 30,000-40,000, but can be offered lower.
Okay.
Yeah, yes, Siddharth?
Regarding the FNAC, I mean, if it comes as category 3, my query is like, can we do a core biopsy and send for an NGS? Is it going to make any difference?
You could actually send even the FNA material directly for NGS. Actually, that's a possibility today.
NGS we can, and how much does it cost?
There are NGS panels which can directly look at the FNA itself and work with the FNA. Even there are a lot of NGS panels which have been described in literature where you could straight away send it for NGS. The thing is about the cost. Okay, so people are worried whether to use what has been developed for on histopathological samples, whether that could be extrapolated. But if the lab is very careful in validating it, it's possible that you could straight away send it for NGS.
And it
Now, most of the panels that we have described, the ThyroSeq, etc., ThyroSeq version 2, version 3, all that is an NGS-driven panel. Okay, so if the lab that you're working with is very confident that they could work with FNA, and if they have validated it on a subset of FNA. See, the 72 gene panel that I have spoken to you about now, which is available with us, has not been validated on FNA. It's validated to be performed on tissues. So we're very confident it will work, once the histopathological sample is available, but we are not very sure it will work with an FNA. When it comes to an FNA, you need a well-validated system which could work with the FNA So, and you have to make sure that your panel covers everything that is required. That is also there. A good number of fusions, which may not be represented like in the panel I spoke, also have to be factored in. And if the lab that you're working with already has a validated panel, you could very well go with that. Like Dr. Paul said, there are several who develop it. Unless it's published and the literature is available, we won't be really able to figure out. So there may be someone offering it already, but what you as a surgeon need to look at is what is the level of validation. Now, if you go down to the ETA guidelines of 2018, ETA also tells you the same thing. Use a panel, that is very important. But what they go on to say is the surgeon needs to look at the validation process of the laboratory and whether they are very sure that it can work on an FNA sample.
Thank you.
Do you have studies on how these things can be used in follicular neoplasms and this minimally invasive follicular cancers, or to prognosticate that? Is it helpful in that?
Which studies do you mean?
No, do you have
whether these markers can be used?
Yeah, markers can be.
Certainly. See, there are huge, I personally don't have experience, but there are a huge number of papers which will tell you what sort of markers may be useful even when, even if it's NIFT-P and whether you need to reclassify them. There are papers available, and there are papers which have gone on to say that the way they have developed their markers, that they can actually establish NIFT-P being in the benign category. There's a paper by Tito et al. From Russia, which is recent, where they've actually factored that in and included markers in their panel in a way that can actually reclassify NIFT-P. So things like that. So there is a lot of literature out there. Now, how much of it can be established here in India? And the cost is a very huge factor for us. So based on that, the labs that you work with, you could encourage them to set up a panel.
Ma'am, like when you see the prevalence, is it the prevalence of your particular area or is it around which you use this rule in and rule out?
Actually, the guideline says prevalence at your institution. That should be factored in.
Okay.
No, prevalence at your institution has to be factored in for you to decide how well it functions as with a good negative predictive value or a good positive predictive value. Then you know whether it's a good rule-in test or a good rule-out test.
Okay, ma'am. Thank you, ma'am.
Thank you. With that, we'll end. Thank you, Rekha, very much. That was a wonderful presentation. And lunch, yes, hungry syndrome is operating. Supriya will announce.
We'll break for lunch now, and we'll be having the rest of the poster work also during the lunch break. So Sean will take care of that. I hope everybody has had a sumptuous lunch, and now we can start the afternoon session. It's going to be an interesting session of master videos. So may I invite Dr. B.N. Mohanty to moderate this session, sir, and Dr. Surbhi Karkias, please, to show us a master video on hemithyroidectomy.
Friends, welcome back to the post-lunch. This is always, master video session is always an exciting session. So we have at least 7 to 8 master videos to be presented. So we'll start with Dr. Surabhi Garg. She will be presenting hemithyroidectomy master video. Dr. Garg, please.
Thank you, sir. Good afternoon, everyone. Firstly, I would like to thank the organization, Paul sir, Sabha sir, the organizing committee, and of course my teachers for giving opportunities to young surgeons like us for presenting on such a platform. This lecture is more for the residents. Firstly, prior to starting the video, we need to know the definition of the term hemithyroidectomy. Usually in the textbooks, the terms lobectomy and hemithyroidectomy are used interchangeably. But hemithyroidectomy actually defines the excision of the lobe that is involved, plus the isthmus, plus any embryonic remnants like the pyramidal lobe or the thyrothymic rests that may be present.